Okay, everyone, hopefully if we're live, people can hopefully hear us all okay. Is the live stream? Yes, excellent. Okay, live stream is go. Okay, good morning, anyone who has joined in early on this Saturday morning. Welcome to the virtual surgical placement, I suppose, in association with Medics.Academy. Just very quickly go through the itinerary for the day, and we'll do a quick recap in about 10 minutes for anyone who joins us afterwards, just to give an idea of what's going to happen today, what we hope you will get out of it, what we're hoping to get out of it, and how you can take part. So the first thing to say is that hopefully all of you who are watching have been sent a pre-placement questionnaire to fill out. So we've asked you some questions about your current knowledge of surgery, how you feel about surgery, a career in surgery, including anyone who is not yet a medical student, who is a clinical year or a preclinical medical student. We're trying to capture your current level of knowledge, and then we're going to run through this day. We're going to ask you a set of similar questions at the end of the day, and then hopefully we will have made some sort of positive difference. But we've got certificates for you already. So all you have to do in order to be sent a certificate is make sure that pre-placement questionnaire is filled out. Then we'll send another one at the end of the day, and anyone who fills out both the pre-placement and the post-placement will be sent their certificate, which will look great for your portfolio. And yes, I'm just getting notifications from our dedicated Slack channel for today. So hopefully you can see on your screen, we've got a come and ask questions slide. You'll need to go to this link on your screen now, or you can use the QR code that should be on screen to come and join our dedicated Slack channel for the day, which will let you ask questions during any of the sessions. We'll all be monitoring the chat all day. So if you just drop your questions in there, sign up to Slack, come and join our dedicated chat channel, and one or more of us will respond to you either in the chat or hopefully on the screen. So we've got some fantastic speakers lined up for you, including a team of newly graduated doctors, two of us medical students here, and some very illustrious guest speakers as well. So we're really excited to bring you the event today. So I think we're just on the verge of 11 o'clock. We'll quickly have a run through the timetable. So we're going to start first thing with a survival guide for your surgical placement. So a lot of people find surgery a difficult or uncomfortable block, or maybe nerve-wracking when they're at medical school, because it's a completely different environment to maybe being on the wards or learning with each other. It can be quite fast-paced environment that's unusual. Not many people have experienced surgical theatres before, and there are certain behaviours and etiquette that might be expected of you, and it's easy to make mistakes. Dr. Chris Greco is going to go through his very excellently written survival guide for your surgical placements. He's going to cover, how to prepare for your placements, what to do, who to speak to, basically how to look after yourself, make sure you have an enjoyable and productive time on your surgical block. If you're a medical applicant or a preclinical medical student, it's still well worth paying attention and taking some notes, because all of this stuff will come in useful for you further on down the line. Then we have a session on optimization and fitness for surgery with Dr. Vijay. After that, so fitness for surgery is a really important topic, because you're never going to be sure that any particular patient is going to withstand or be suitable for the type of surgery that you might want to do on them. And obviously, it's not just the surgeon in the operating room. There's an entire team, of which an anaesthetist is a critical part. They're responsible for looking after the patient, making sure they're breathing properly, they're vitally stable, and the surgery can proceed. And making sure that patients are safe and ready for surgery is a really important part of the process. So that's everything before lunch. Then we'll have a short break until 1:15, where we'll be doing a typical pre-op surgical ward round. So in the morning, surgeons might come onto the ward, have a look at all the different people that they've got in, and we're going to run through the more medical side, care of the surgical patient, as it were, sort of looking at the different surgical conditions that can affect patients, how you might want to manage them on the ward, make sure they're safe and healthy. And that's going to be with Anna and Luann from our organising team. Again, really pay attention. It's good stuff for exams, really common question material, because it's not just what happens in the operating room. You've got to run through, the observations, the types of conditions, the risks of having people in for surgery and how you can look after them properly. Then at 2:00, you'll be doing some basic surgical skills with myself, where we'll be learning something about the basic instruments that you might need to do surgery, talking about sutures and how you kind of manage them safely when you would use different types of instruments. And then I'll be showing you some basic knot tying. So tying knots is a really useful thing to be able to do as a med student, because sometimes you will have the opportunity to tie in theatre, or sometimes on the wards, things need to be sutured. Just yesterday, we had a laceration come into the emergency department, and that was a great chance for us medical students to use those skills if you have them on the ward. So it's a good thing to be used to. Then at 2:30, we have a virtual surgery and anatomy session. This is really exciting. So you're going to go through a real case with a surgical registrar, a very senior surgical registrar, Miss Merker, who will walk you through an operation. And I would really encourage you to ask loads of questions, because it's really good exposure to a surgical theatre and an operation that you usually don't get to see very often. Then we'll have a short break. Then we'll move on to our post-op ward round. So have a look at managing patients post-surgery and some of the post-op complications that can develop there, making sure these things don't happen. Again, reminder that surgery is this continuous process. It's not just the operating theatre. It's bringing them in, making sure they're safe on the ward, making sure they're fit for surgery, having the actual surgery, making sure that goes okay, then bringing them back safely onto the ward, allowing them to recover optimally, and then when they're ready, sending people home. Then at the other end of the day, we'll run through a quick summary of what we've been through. It's your chance to ask any final questions. You can just pitch anything you like, add us in the Slack channel. I mean, that's true all day, but obviously better to keep it on topic in the Slack channel. And again, we'll run through the post placement questionnaire at the other end of the day and make sure that you can all get your certificates. And we try and learn as much as possible about what we've all managed to achieve together. So where are we? 11:05. Just a very quick piece of information governance, because a few of you have asked about the survey. Obviously, we asked you to provide some data for us, which we hugely appreciate. All we're hoping to do is, as I said before, look at your understanding and appreciation for some of the surgical concepts before the day. Then we'll measure the same questions at the end of the day and see if there's been any difference made. And we hope to take the data that we gather from this day to a conference to present the results and kind of show the world what we found, what's gone into making this virtual surgical placement, and some feedback from you guys, because that feedback's really vital. We need it to make these days run smoothly, and other institutions can learn lessons from what happens today. We can kind of engage with the international community. Special thanks to Luxna and Nadine, our two Foundation Doctor moderators, who have been absolutely instrumental in making this day come to fruition. I think this is an unusual event that's happening, a completely free day of virtual webinars. COVID has forced everyone to look for new solutions, and it's only with more experienced doctors and moderators like Luxna and Nadine that allow these things to happen and give us the guidance that we need to make it all run smoothly. So we'll just do a quick run through of everything we've just spoken about, just for anyone who's joined a little bit late, and then at 11:15, we will kick off with Chris and his survival guide. So this is a virtual surgical placement with Medics.Academy, where we are hoping to replicate some of the features as best we can of the type of surgical placement that a medical student might experience during their more clinical years, so years 3, 4, 5 of medical school. That's a really important part of learning to be a doctor. Surgery is very much its own environment and has a particular set of concepts and skills associated with it, but it forms a crucial part of medical school and learning to be a doctor. So we have a session on surviving your surgical placement, first thing with Dr. Chris Grieco, who is a newly graduated doctor in general surgery. It's had a very kind offer to start quickly if I run out of spiel, which I think we will do. There's no sense boring you again. So optimization for surgery after that with Dr. VJ, a consultant anaesthetist. Then got our pre-op surgical ward round, a set of surgical skills, basic knot tying, getting you used to the idea of suturing. Then a session on virtual surgery and anatomy with a registrar in general surgery, Miss Merker. Quick break, a post-op ward round, managing patients post-surgery, and then some closing remarks. So I think I will spare you any further spiel. From all of us, I guess, on the organizing team, we hope you enjoy the day. There's a lot to cover. It's going to be intellectually stimulating, hopefully not too intense, but we hope you enjoy yourselves and learn a bit from the day. So without further ado, I will pass you over to Chris.
Hi guys, thank you Ollie for that introduction. That was fantastic. I'll start sharing my screen now so you can all see the itinerary for the day. Ollie's obviously gone through all this with you already, so I won't go through it too much. So I'm starting off with a surgical placement survival guide in 10 top tips. So a little bit about me before we start. My name's Chris. I'm a recent University of Bristol graduate, and I'm now working in colorectal surgery in Taunton, which is just south of Bristol in the southwest of the UK. I'm aware there's quite a lot of international viewers today, as well as British viewers. This talk is directed at my personal experience, which is from my experience at University of Bristol. So I have focused on the British curriculum, but you know, a lot of these lessons are very transferable. So I just want to say why I'm giving this talk today. I found a lot of advice was very generic, suggesting to do things like be friendly, be engaged, be proactive. Yes, it is good to do those things, but this guide is designed to give you some more specific advice for a medical student that's just about to embark on a placement in surgery. I wish I'd received something like this before I started. It would have made a big difference. So here's a quick overview of the things I'm going to cover today. I'm going to start off talking about e-logbooks. So here's something you can do right now. Hopefully you'll be going back to university fairly soon, and hopefully you'll get a chance to go to theatre and observe or assist in some surgery. Only if you want to, that is. It's not for everyone, so don't feel pressured. An e-logbook is super easy to set up. This is something you can literally do right now. Open your phone if you're not watching this on Zoom or YouTube on your phone, and literally type into Google e-logbook surgery. There's a whole host of online logbook providers now. Some do charge a fee or a subscription for a slightly fancier aesthetic, but in my opinion, the best one is still elogbook.org. It's free and it's the most widely used, plus most consultants in the UK and Ireland are already logged on the website. So you can find their details and easily upload a surgery and associate their details with it. It just gives you space to keep track of procedures that you've seen. I observed and scrubbed in a few operations when I was in 3rd and 4th year of medical school, but I didn't have a logbook then and I didn't know about it. So I didn't record any of them and I don't remember anything about them now. So that's one regret that I have, and I wish I'd known about this earlier. It's okay to ask for a patient's ID sticker from the notes at the end of an operation. It's not any sort of concern about confidentiality. surgeons will have been through the same process, so feel free to ask for a patient ID sticker. Basically, the broader point here is to keep a diary of anything worth keeping a record of. Keep tabs on what you do. If you can't remember later, or you haven't written sufficient details down at the time, it's really hard to prove what you have done. And this goes for anything in medicine or in life. You can have certificates for things, for all sorts of events, such as this one today. So keep a folder of those certificates somewhere on your computer that you won't forget about them. Even if you don't think you want to be a surgeon now, you may well change your mind down the line, and it's good to have a logbook already on your phone, ready to go, so you can, when those opportunities do arise, you can quickly upload your surgery to that logbook. All right, moving on to number 9, Americanisms. This is really important for British students out there, and I'm going to start by telling a slightly embarrassing story. So who loves Grey's Anatomy, or Scrubs, or House, or The Good Doctor? And who follows Dr. Mike or Dr. Pimple Popper? They are great. We love to watch medical dramas, especially American ones, because they focus way more on the drama than the British ones. But beware of unconsciously learning medicine through these TV shows. It's really easily done. I had just started my clinical placements as a very green third-year medical student after spending most of the previous year of intercalation watching the 10+ seasons of Grey's Anatomy. I heard there was a child with appendicitis going to theatre. I asked the surgical team, all of whom I'd literally just met, which theatre is the appendectomy happening in? And after their eyeballs have returned from rolling to the back of their head, a very kind surgical registrar took me to one side and gently explained that an appendectomy is something which happens on US television, and the common operation to remove one's appendix is called an appendicectomy in the UK. So very, very similar terms there. I went very red and apologised profusely, and they let me scrub in and observe the operation. The very document that I was typing this script on today tried to change my spelling to appendectomy, so don't worry if you've made this mistake too. Here are a few other Americanisms to be aware of, particularly for those British students watching today. There's some very common drug names in the US that you might have heard of, such as epinephrine and Advil. We Brits refer to them as adrenaline and ibuprofen. A fairly common illness, glandular fever, shortened to mono in the States for its other name, infectious mononucleosis. Surgeons in the US retain their title as doctor, whereas in the UK, they're called Mr. and Miss. And the people that put patients to sleep, they are called anaesthetists in the UK, not anaesthesiologists. You'll be hearing from a consultant anaesthetist in the UK in the next talk today. So, one that causes some confusion is specialty versus speciality. Most people use them synonymously to describe a branch of medicine, and some think the former, specialty, is an Americanism, but in fact it's not. The GMC and most formal British and American text uses specialty with one eye. All right, here's the big one, university expectations at number 8. So this is the most crucial thing to surviving and succeeding in your surgical placement. Knowing what your specific university expects of you is a fundamental thing to master in the transition from preclinical to clinical placements. Figuring out your university expectations and getting your head around it all can take some time, an awful lot of time when you're also trying to find your feet and familiarise yourself with the new surroundings of the hospital, meeting loads of new people and studying the enormity of medicine for your exams. Basically, reading through your induction pack properly and knowing what your university is expecting from you is key. If you've got on top of this stuff in the first week or two, you can relax a bit and start spending some time choosing what you want to do rather than chasing signatures, whether that be spending time clerking or spending more time in theatre or just leaving early to go and play sport on a Wednesday. I remember feeling very overwhelmed trying to absorb everything that you have to on your placement during your induction day, whilst also posing for a picture for your new smart card, creating 5 different IT logins, having loads of paperwork to sign, and death by e-learning. It is a lot, and you'll get all sorts of paperwork, a welcome pack, a book of sign-offs for clinical competencies and attendance as well at various things like teaching, and you may have to set up a digital portfolio if that's how your university operates. I'll touch on a couple of these things later in a bit more detail. You should be broadly told what is expected of you for the duration of that block and what the expected outcomes are. But there are unspoken expectations too. So talk to your friends. This will be a lot to take in on your first day, and most people will be exhausted after that first day, which is completely normal, but it's good to be ready for this. My tip that I would really encourage is to actually just sit down and crack through this, reading your induction pack and your timetable to get your head around it for your university specific expectations. And as I've said, these will include things like clerkings, clinics, ward rounds, clinical skills, and hopefully some theatre time as well, in addition to your attendance at teaching. So, moving on to number 7, where do I leave my bag? We've all been in this situation, and if you haven't, then I'm sure you will pretty soon, with hopefully clinical placements set to restart pretty soon, maybe in September. Maybe some of you have already restarted, but it's your first day. It is okay to tell people on your first day, it is my first day. I often find it's actually a great way to start your introduction on a ward. Every clinical medical student has been there, and if you haven't, then you will experience this fairly shortly, where you go onto a new ward and you feel like you have to go and talk to someone and introduce yourself, but you're not quite sure who. So a good way to break the ice in that situation, to whoever you come across, it might be a receptionist or a nurse or a ward clerk or maybe a friendly doctor, just say, it's my first day. I'm a medical student. My name is ... You can fill in the rest. But 99% of the time, this will cause them to cast their mind back to a memory of their first day, and they'll want to help you. They are, of course, all healthcare professionals, so they're generally caring people. So this tip, where do I leave my bag? You're in a new environment. After introducing yourself, this is the first problem you'll face. Don't worry, you'll usually have to bring a bag into university to carry all that paper you were given on your intro day, and something to write notes on in teaching, or a clipboard to keep your clerkings in, or just to carry in your lunch. So what we're really talking about here more broadly is logistics. So how are you commuting in? You don't live in the hospital or right near the hospital, so likely you'll have to figure out the best way to commute in. There'll be things like parking. Where do you leave your bike if you're cycling? How long does the walk take? How much does the bus cost? And can I get reimbursed? You might have had a new commute, so give yourself some extra time on that first morning. Set that alarm 15 minutes earlier and do some meal prep the weekend before. These are all new things that you need to think about, and having thought about them beforehand and figured out a strategy that will work for you will save you time and stress on that first day. So this is all about knowing your way around the hospital and finding how things are done there, because I can tell you for certain that in every different UK hospital, there's a different way of doing things. So who are the best people to ask for these specifics? You can ask students in your year that have already done a particular placement in that particular hospital, or a student in the year above. I'm sure they would be more than happy to help. You'll probably get an intro email from the admin staff, and their job is to help medical students. So they're more than happy to answer questions via email. Remember, those admin staff are a great source of help. They have years of experience and know exactly how things work in that specific hospital. If you would like to have a shower on arrival, for example, if you've cycled in, or you want a locker to leave your stuff in, or you want the code for the changing rooms where the scrubs are kept, ask them, how do I do that? Can you show me? Another great group of people to talk to are the F1s. They're the brand new doctors that still remember what it's like to be a student, particularly in those situations where it's their first day. Those F1s will have had exactly the same feeling pretty recently when they started their new jobs. So if you need somewhere to leave your bag, you can ask them, and they'll happily show you where the doctor's office is, or where is an appropriate nursing bay where you can safely leave your bag or other belongings. Okay, next up, number 6, who's who? So like I said, when you walk onto a ward or into theatre, you don't know who anyone is, and each hospital staff wear different uniforms, so it's difficult to know who everyone is when you're first meeting a whole group of new people all wearing scrubs. So I'll briefly just explain the hierarchy of a surgical team. this figure is from Royal College of Surgeons, and that shows you nicely sort of the structure of a surgical team. So in a surgical team, there are doctors and nurses of different grades. I'll start from the bottom and work up in terms of hierarchy. So as medical students, you have a vital role to play within that team, and you will be expected. You may not know they may not know your name on arrival, but it's then your job to introduce yourself. So don't be offended if someone asks for your name again or they forget your name. There's a high turnover of students, so just politely remind them what your name is. There will be F1s and F2s. These will hopefully be the friendly faces that you can talk to. And the crux of later clinical placements is shadowing and pretending to be them to learn exactly what they do in their job. It won't be long until it's you. Next is a group I only started to fully appreciate as a final year student. These are clinical nurse practitioners. They are senior nurses, basically consultants of the nursing world, and they have decided to commit to one specialty because they are particularly interested in it. They have vast amounts of experience, and they're usually very friendly, and hopefully they'll show you the ropes. CNPs work more closely with patients day to day than most doctors do, so they are great people to shadow to do clinical procedures. Next up, above F2s are core trainees. So core surgical trainees have decided that they want to pursue surgery, and they're at the first level of specific surgical training. So they rotate around different surgical specialties like colorectal, upper GI, urology, and vascular surgery. And along with them, the next ones up are registrars, and they run the day-to-day ward rounds, and they are the people that the consultants trust to make their decisions on a day-to-day basis while they are too busy in clinic or meetings or operating. They also do a lot of operating themselves, so they're good people to get to know if you want to spend more time in theatre. You might see acronyms like SAS or SPR, and these stand for Surgical Associate Specialist and Specialist Registrar. They're practically consultants, but work at a registrar level due to consultant job availability or passing their final completion of training exams. So nearly at the top of the tree, we have consultants. And remember, all surgeons and from core trainees upwards have the title of Mr. or Miss in the UK and not Doctor, which is good to remember when addressing them. At the top of the tree, in my opinion, are ward nurses and scrub nurses. They provide the vast majority of direct patient care, so are undoubtedly the most important in my mind. You may not agree with me, but this attitude will serve you well, as they can teach you so many valuable lessons, from practical skills to the more intricate communication skills that are quite difficult to learn from surgeons. There are a number of other members of staff as well in the hospital, from porters to dietitians, all of whom play crucial roles. Pretty much any of these people can sign your logbooks. So make sure you're familiar with your logbook and ask for signatures. It's always good to mention your logbook early on so people aren't surprised if you do ask for a signature. All right, here's a quick recap of what we've covered so far. We've looked at e-logbooks, and if you haven't created an account already, then make sure you do that. Americanisms, some key ones not to slip up with like I did. University expectations, where do I leave my bag, and who's who. Next up, we've got IT systems and apps. So just a quick word on IT systems and apps. This is something that's so easy to get completely bored out of your mind with during your induction. You might think it's not worth having all these logins, as the placement is only 6 or 9 weeks long. Do I really need to get all these logins sorted and have an email account and all the rest of it? I would urge you just to try and pay attention in those IT sessions. Make sure you get all your accounts set up properly on the first day, as it will save you time and effort in the future. Pardon me. If you do run into any problems, IT are really helpful, and they're just a phone call away. They're literally the most helpful people in the hospital. You can just give them a call on any of the hospital phones, usually one in the library or on any ward, or even on your own mobile with one of the apps I'm about to mention, and say, I'm having this problem, can you help me? And I'm sure they will. So what's the reason? Why bother with IT systems training? It's because having your login sorted and knowing how to access the different hospital systems on the computers, iPads or iPods will make you so useful when it comes to becoming part of the team. And that's what most medical students want. They just want to feel like they are part of the team. All right, I'll tell you specifically why when we go on to talk about ward rounds in the moment. Apps. So if you're not using your phone to watch this, then you can take out your phone right now and go to the App Store, and feel free to download any of these that I recommend. And the first one I'm going to start with is BNF. And if you're a medical student in Britain, then it's pretty much essential. All the drugs, their doses, and their indications. Next up, we have an option of two, micro guide or RX guidelines. So depending on what your hospital uses, it will be either one of these apps probably. This provides hospital-specific antimicrobials. It makes antibiotics a lot easier to learn on placement if you can refer to these apps to see exactly how they're prescribed in your hospital. Next up is Touch Surgery. So on this app, you can watch actual surgery with walkthroughs written by surgeons and learn from step-by-step animated guides on how to operate. One of the talks coming up a bit later is the surgical walkthrough, and that uses Touch Surgery. Okay, this is quite a university-specific one, but if you have an e-portfolio, get it logged in on your phone so you can upload clinical skills and other things and get signatures as and when you do them. You can physically hand over your phone to a doctor or a nurse and get them to type a comment for you on your phone. This is much more convenient for them than answering an email later on. Make sure you've practiced using it so that when you have that first encounter on the wards where a doctor or nurse asks if you'd like to have a go at taking bloods from a patient, then you already know how to navigate to the website afterwards, where you can click and upload the clinical skills after that procedure. You can type in the date, the time, and who observed you and who signed you off. Maybe you could bookmark it on your phone or create a little app shortcut. It's harder to do to upload clinical skills retrospectively. So I haven't actually touched on any academic learning in this talk yet. This is intentional as this guide is more focused on the practicalities, but find some resources that work for you. Stick with them. For me, it was PassMed. In my opinion, the best and most complete question bank, and the comment section is hilarious, and it breaks up those unending questions. So personally, I tried to do a few PassMed questions a day that were appropriate and relevant to that placement I was on. Some others for later on, for when you're a doctor. These are all sort of daily use apps for junior doctors. Induction, Pocket Doctor, and Foundation are all, I use them every day when I'm on the wards. Induction in particular, this is the one I mentioned that allows you to call any number in the hospital from your mobile. So you just type in the 4 or 5 digit extension code and Induction does its magic. And for example, you could call IT on this and it would save you having to find a dedicated phone on the ward. So if you have a commute, then podcasts are great. Zero to Finals is incredible for learning all of clinical medicine. Surgery 101 is good and it's specific to surgery. There are so many more medical apps like Capsule, which was recently launched by the Medical Schools Council, Osmosis, Sign Up. Just find what works for you and stick with it. That would be my #1 tip. Don't go swapping between resources too much. Just stick with what works for you. All right, the ward round. On a ward round as a medical student, you can often feel like a spare part and that there's not much point in going. I'm going to show you why that is not the case. In surgery, the ward round is basically where the consultant or the registrars, along with the junior doctors and clinical nurse practitioners, go and see every patient under their care. At the start of the day, they do this and they see every patient on their list. So where do you fit into that as a medical student? So you just turn up and join them and become part of the team. And you might not be timetabled to do this for many days at all, maybe only 1 or 2. But there's still place for you as a medical student, so don't feel like a spare part. The days in surgery start earlier than in medicine, 8 AM rather than 9 AM. So that means the F1 or other junior doctor is in at 7:45 to edit and print the patient list, or the digital alternative if your hospital is paperless. If you have morning teaching or something else is scheduled in the morning, it may seem like there's no point in going to that ward round. But you can still go to the ward round and then leave at like 8:45. The team would not mind at all if you leave for teaching. So what I would recommend is setting yourself the challenge to commit to going to 1 full week of ward rounds, so 5 straight days. You'll get into the sleeping pattern and it shouldn't be too hard to make the 7:45 start after a couple of days. Why I say this is because I feel like going for a ward round 1 or 2 days is not really enough to make an impression and feel like part of the team. But turning up every morning for a week will lead to boundless opportunities, and you'll have chances to then meet people to go to theatre with or to learn some surgical skills from, and also get more sign-offs done very easily. So you can also leave the ward round, like I said, to go to other commitments and then come back to the ward later on to help the F1 with the ward jobs, or go to theatre. So ask the consultants and registrars whether you can scrub in with them for any operations later in that day or later in the week. So other than networking, what can you actually do on the ward round? This is where that IT induction will pay dividends. You, with all your logins, you can check the patient observations, their news scores, if you're familiar with that term, blood results, and recent scans like X-rays, CTs. And you can also help by writing in the notes with the help of the F1. So by knowing or having immediate access to some key information about these patients, you can actively contribute on the ward round. The senior doctors won't know this information off the top of their head, so they'll be asking you and the junior doctors for this information. It's quite easy to get involved. You can just log into a cow or a goat, computer on wheels or gadget on a trolley, or pick up an iPad or iPod from the ward to get access to this information. Whatever system the ward uses, you should be able to log in using your IT logins. Surgical ward rounds are notorious for being very rapid, but it's more important that you don't write anything incorrect in the notes. So there's always time to clarify the plan for the day before you write it down, and just say to the consultant or registrar, sorry, I just want to clarify this before I write it down. Can you just recap what the plan is for this patient? It may feel like you're being the immovable object between the consultant and their morning coffee, but trust me, that coffee can wait 1 more minute to ensure the plan is correct and safe. Okay. If you do ever feel like a spare part when you're on the ward round, just remember that if you're on placement in a hospital, it's a teaching hospital, and teaching hospitals receive income for students being there on placement. And it's within every doctor's job, they have a responsibility to teach juniors. So do not feel like you're taking up anyone's time. Moving on. Theatre. This is probably the one a lot of you budding surgeons are looking forward to. So, arguably one of the most exciting aspects of surgery, and that is the surgery itself. I take it by joining today's webinar that you have some interest in maybe doing surgery as a career. A couple of key points: be on time and be opportunistic, because if you don't leap at the chance to go to theatre, then it's likely they'll have to start without you. And it's very difficult to just join an operation midway through. So you may be scheduled time in theatres, which is great, but don't feel like you should then turn down opportunities at other times as well. There are 2 broad types of surgery: emergency and elective surgery. Emergency surgery is relatively unplanned and urgent, whereas elective surgery is planned. A lot of surgery is actually the majority at the moment during COVID times is emergent. And hopefully this will return to the norm soon, with the majority being elective. But emergency surgeries, won't wait. So if if you've got a patient that has an aneurysm and they're actively bleeding, they need to go to theatre straight away. So if an opportunity like that appears to you, then I would say scrub in, get involved, and it's okay to be late for one teaching session. And your teacher should understand that, it's good to take those one-off opportunities. So another thing to add is to own some Crocs. As you can see from the picture here, I've put some Crocs on there. They're incredibly comfortable and stylish, so why not get your own pair? I saw in Lidl the other day, you can now buy Crocs for £3.99. You'll be expected to wear them in theatre, and rather than panicking that you'll be late, while looking for 2 odd Crocs lying around the changing rooms to borrow, you'll have no such troubles if you just bring your own. Knowing where the changing rooms are and the code for the door is another thing to consider. Just use that trick again. It's my first day. Can you please show me where the changing rooms are so I can get changed into scrubs and go to theatre? Surgical skills are quite poorly taught in most medical schools, purely because you may only have 1 or 2 surgical skills sessions throughout the entirety of medical school. If you've never tried suturing or knot tying, don't worry, they're not too complicated to learn at home with things lying around the house, which I'm sure Ollie will show you a bit later. You will have much more confidence in theatre if you've already had at least 1 go practicing these at home without the pressures of being scrubbed. From my experience, most surgeons will happily get you involved, even if you've literally just watched a recent YouTube video on surgical knots and you've practiced with some shoelaces. That will put you in better stead than if you've never done anything. If offered, then maybe try some suturing, obviously with the supervision of the consultant or registrar that's doing the operation. Remember, these opportunities only come if you've asked to scrub in at the start. So it is good to get to theatre a little bit early for that theatre list that you've been allocated so that you can ask to scrub in. The way that I first learned any surgical skills was whilst killing time between operations. So on a day case list, where there's lots of patients and who are having shorter operations, one after the next, there's actually a lot of time in between those cases because it takes time for the anaesthetist to put them to sleep, wake them up, send them back to recovery. So that's where you'll have time and you can talk to the surgeons and ask, maybe even over a coffee, can you please teach me some surgical skills, just some knot tying? So in terms of these clinical skills as well, where are good places to get things done, to take bloods, to do ECGs, that sort of thing? I found from my experience, the pre-op assessment clinic, otherwise known as POAC, is a great place to go to get all sorts of things done. Every patient having an elective operation will go to this clinic and they'll have a barrage of tests done. So you can go and help the nurses there to take bloods and do those things. Other places to go that are good for clinical skills are SAU, which is the Surgical Admissions Unit, and ED. All right, PPE. We've managed to get to number 2 without mentioning COVID. Well, not really. I find that quite amazing, considering everything that's going on, but we do have to talk about it as things have changed a little bit in hospital since, and it will be remiss of me not to mention PPE. So you'll probably know that at present, all healthcare professionals are expected to wear a standard surgical mask anywhere in the hospital. And then when touching patients during an examination or taking bloods, you have to wear an apron and a pair of non-sterile gloves, and sometimes goggles or a visor. Operations are classed as an aerosol generating procedure, or an AGP. So at the moment, you now have to be fit tested to wear a special mask like the one you can see in the picture there, regardless of the patient's COVID status. Hopefully that won't be a barrier for you attending surgeries, but it's important to be aware of at the start of your placement, as you can ask the admin team how you might do this fit testing. You may have to book in to do the fit testing using one of those pesky IT systems we've spoken so much about. A top tip for gents as well is to be clean shaven the day of your fit testing and any subsequent days you might go to theatre. You will almost certainly fail the fit test, like I did, if you're not clean shaven, as the mask must form a good seal with your face, so as not to allow any aerosolized particles through that are generated in the procedure. As a formerly bearded man, this is just another way that COVID had personally affected me. All right, moving on to number 1. And I've left this to number 1 because I think it's probably the most important. Getting organised. That is the crux of clinical placements. And I only really realised this when I started working. I wish I'd known a bit sooner that medical school was designed very carefully, and its main purpose is to prepare you for working as a doctor. That makes sense, right? Yes, as a student, you have constant, unending teaching to prepare for exams. But what are all the other logbooks and portfolio stuff? What's the point of all that? So now I realise, and I wish I'd realised earlier, that this is to teach you the most fundamental skill of being a doctor, and that is being organised. Yes, it is a skill. Much like any other skill, it takes practice. The good thing is you won't be expected to have perfect portfolios and logbooks and 100% attendance at teaching, but clinical placements are where you learn how to do those things so that next time around it's less tasking. One of the university expectations may well be to create a portfolio for your clerkings. So clerkings are what you produce when you've gone to speak to a patient, maybe one that you've met on that ward round that you went to, and taken a proper history and done an examination, and then maybe come up with some differential diagnoses and a plan. So this process not only improves your documentation, your communication skills, and your medical knowledge, but it also has a secondary benefit. And by producing a portfolio of your clerkings, it's basically a warm-up for what it's like to prepare a portfolio for when you're a doctor, and you'll be applying for job applications with this portfolio. I'm not trying to scare you at this point by thinking too far ahead, but it's just good to be aware of at times when you think these portfolios might seem a bit pointless, that there is actually a reason for them, and they're all good practice. So your logbooks and e-portfolios in medical school are designed to help you prepare for what it's like to be a doctor. Makes sense, right? So don't worry about these terms now, but and what they mean, but it's good to become familiar with them because there will be constant requirements for when you're a clinical medical student and a doctor. Things like CBD, Minicex, DOPS, and TAB. Those are all things that will make up your e-portfolio, and it's just good to have heard those things before you start your time on the wards. And so these are all sort of hurdles that you have to hoops that you have to jump through, and hurdles that you have to get over when you're a clinical medical student and doctor. All right, so just another quick recap of what we've gone through today. I'm now open to answer any questions on the Slack, and I'm more than happy to, if you want to direct message me or tweet me. And I'll be around all day to answer questions in the Slack as well. So if you'd like to leave me some personal feedback, that would be great. You can snap this QR code and fill out I think there's 4 or 5 questions on there, but it's not a requirement, so don't worry if you don't feel like it. Just want to say thank you all for watching. I hope you enjoy the rest of the day. I think there's some really, really exciting content coming up. And we'll go back now if you've had a chance to snap that QR code if you want to. We'll go now to the itinerary, which you can see. And next up on the list is Dr. Vijay Chikkabaya. He is a consultant anaesthetist at Nottingham University Hospital, I believe. So if he is ready, I will stop sharing my screen now and hand over to him. And today, Dr. Vijay will be talking to you about optimization and fitness for surgery. Okay, if you'd like to go ahead and share your screen. There we go.
Thank you, Chris. Can you hear me?
Yes, you're live, Dr. Vijay.
Okay. Oh, thank you for kind introduction, Chris, and thank you for inviting me to talk on pre-op assessment. Today, I'll be talking about optimization and fitness for surgery. I'm a consultant anesthetist at Nottingham University Hospital. My special interest is in regional anesthesia, and I do pre-op clinic for orthopedic patients coming for surgery. So, and also I look after teaching for the core trainees in anesthesia. So as Chris already mentioned about the survival kit, I will go ahead with starting with what objectives I have for today's talk. So first of all, I will talk about optimization and risk stratification and patient-centered care. And going ahead, why do we need to do a pre-op assessment? So first of all, to prepare patient for surgery. Second, we make sure that they are not canceled on the day of surgery because of they've not been appropriately optimized. And by doing both of that, by preparing the patient and not getting cancer, patient has a better patient experience. And also we are going to reduce complication. So having surgery is a big moment. So if we prepare the patients to get through that, we can reduce complications. So who are involved in the pre-op assessment? So anesthetic team is involved, surgical team is involved, physicians, general practitioners, and nurse specialists. So nurse specialists are the ones who initially see the patients when they're booked for surgery. When the surgeon sees a patient and makes them needs a surgery as an option intervention for which they've been referred from the GP, the surgical team then puts them on a pathway. The pathway can be a cancer pathway or a non-cancer surgery pathway. If it is a cancer pathway, it is an urgent pathway where they have to be operated within 18 weeks. Whereas it is a non-cancer pathway, they can take up to 3 months, 6 months, or a year, depending upon which part of the country the patient is, because each hospital has got different waiting list. So this is the time. So if it is a cancer pathway, got only 18 weeks from the time of referral to operating. So we got minimal time to optimize. So it is very crucial for these patients to be optimized in that time duration if it is a cancer pathway. If it is not a cancer pathway, you got time, but still it is crucial time. Once the patient is put on a waiting list, then they see the nurse specialist in a pre-op assessment, but that doesn't happen straight away. So it might take another 2 months before they are even see the nurse specialist. So the surgical team here has got a good opportunity to start optimizing the patient. So I'm going to go through an example and go through the different ways of assessing the patient. So throughout my talk today, I'll be going to this example all the time. So just to make you understand what type of cases we see and how we go about managing in pre-op assessment. So this is a standard patient we will come across in the surgery or orthopedics or any other subspecialties. It is a 70-year-old gentleman coming for elective major surgery. He's got a background history of high blood pressure and cholesterol. This is a standard patient. So first thing what we're going to do is assess clinical features. So the general history and physical examination. So in the pre-op assessment, each hospital has got a different pro forma, how to go about assessing the patients. The best way is to have a good history and good physical examination. So I'm not going to go through the pro forma. I'll go through the systems because each hospital has got different way of assessing. Okay, history part. So throughout your medical school or when you become a foundation doctor, this is what you will be doing day in and day out. But specifics for each one we'll go through for pre-op assessment. Cardiovascular. So the cardiovascular system comes with different comorbidities, can be hypertension, angina, atrial fibrillation, myocardial infarction, or valvular heart disease. And if a patient had a myocardial infarction recently, they might be on anticoagulation drugs like dual antiplatelets, or a patient might have a pacemaker. This is all relevant to anesthesia and surgery if the patient is coming for surgery. So if the patient has an angina, we need to know what anti-anginal medications they have and how frequently they're getting angina. And if they've got atrial fibrillation, whether they are rate controlled and whether they're anticoagulated, because we need to stop the anticoagulant before surgery. Or we need to discuss with the cardiac physiologist if they have a pacemaker and ICD to see whether that has to be programmed before surgery. So any of the cardiovascular risk factors going to affect the patient by having an adverse cardiac event if they are not optimized. Even if they're optimized, they are at a higher risk. So this is what we have to do in pre-op by trying to optimize. Next, going on to the respiratory system. So the respiratory system, we're talking about the different respiratory diseases. Again, we need to look at whether the patient has an asthma and how frequently they're getting asthma attacks, whether they are on appropriate treatment, whether they have been hospitalized or they've been using nebulizers or they've been admitted to intensive care unit, or how many times in a year they've been getting antibiotics, steroids. So these are very important in our pre-op assessment to find out so that we can make plans or optimize them further before they're coming for surgery. And similarly, obstructive sleep apnea, we need to make sure they are completely optimized before they come for surgery. So any respiratory or cardiovascular is going to be major risk factors for patients when come for surgery if they're not optimized, because the respiratory system plays an important role of oxygenation and ventilation, which is very important to prevent any ischemic events. Coming into renal, so renal diseases can cause anemia, and the patient might have a renal transplant, so they might be on immunosuppressants, which is very important to know. Anemia plays a very important role in optimizing anemia, because anemia can pose 4 times increased risk of acute kidney injury postoperatively, and they might be 4 times at increased risk of receiving blood transfusion. So the blood transfusion comes with its own risk of complications of transfusion reactions. And they come with 3 times the increased risk of morbidity and mortality. So here we have a chance to make sure that we identify anemia and investigate anemia and treat it or optimize it before they come for surgery. And endocrine. So diabetes is a major risk factor when they come for surgery, because it increases wound infection rate because of poor wound healing. So by making sure that diabetes is well controlled, we can prevent that. So by having a wound infection, they spend more time in the hospital, which makes them exposed for hospital-acquired infections and complications, which all can be avoided. And thyroid, we need to measure the thyroid function, make sure they are well controlled before they come for surgery. Neurology, again, epilepsy is one of the commonest comorbidity which we see. So we need to make sure they're in appropriate medications, well controlled. And if they're seeing a neurologist and they need to follow the guidance and make sure that they're appropriately taking the medications. If they are not, then we need to optimize them again. So similarly with stroke, we need to make sure that if they're on any anticoagulant, that has to be stopped or needed a bridging therapy before we go ahead with surgery. And Parkinson's, we need to make sure, which is a neurological disorder, which we need to make sure that they take their medications even when they are nil by mouth, because that is a very important, because Parkinson's disease patients can't manage without medications, even if they miss a single dose. So it is very important. Blood disorders. So blood disorders we need to know, because we need to plan for surgery. If they have an increased bleeding risk, we need to optimize. And if a patient doesn't want blood, like Joe has witnessed, we need to have a proper discussion with the patient and the multidisciplinary team to identify how best we can manage these patients. And with sickle cell disease, we need to make sure they don't go into crisis. So we need to manage them by appropriately managing strategies, like if you're coming for a lower limb surgery or upper limb surgery, whether the tourniquet can be used, or if not, a quick procedure, and managing them is the best way of going ahead. So specifics for anesthesia and surgery itself, apart from general history taking. So we need to identify whether the patients had any complications or reactions to general anesthesia previously. Malignant hyperthermia, which is one of the conditions, it's an autosomal dominant condition, which leads to metabolic state, leading to life-threatening event, which has to be identified if they've had a previous exposure or a family history, so that we can make a different arrangement or an alternative anesthesia plan for these patients. And pregnancy. So if a patient is pregnant and needs a surgery for non-obstetric reasons, then we need to think about the medications and involvement of multidisciplinary team. And in terms of airway assessment and difficult intubation, we need to make sure that we have an appropriate skill mix on the day and plan for the day. And if a patient can't consent for themselves, we need to get involved, have a mental capacity act by independent advisor to make sure that they are appropriately consented. So these are the specifics which we need to look at in pre-op assessment, so that this doesn't crop up on the day of surgery, and then we might not be able to arrange for the skill mix and the personnel, and the patient gets cancer. So these are the reasons why we should make sure that these are all picked up in the pre-op assessment. So functional status. So we have done a general history. Now we need to ask about what exactly this 70-year-old gentleman can do. So whether it can go jogging, which means that it's got a very excellent functional status, or it can just about do cycling, climbing stairs. That is a moderate function. And very poor functional status, we say, which is just about walking and not doing much at all. Okay, so why do we need to know? Because this is the only way we can assess from the individual how much of functional status they have. So why is it important? Because it equivalents to metabolic equivalent. So one metabolic equivalent is the oxygen consumption by a 70 kilo man at rest. So this is very important. So if a patient has a poor functional status, we say is they've got less than 4 METs, which is which necessitates further investigation of cardiorespiratory system to see whether they can withstand surgery. So in the previous talk, Chris mentioned about anesthesiologists, that this is the American Society of Anesthesiologists grading of patients according to their comorbidities. So which is gives a very good view of different categories of patients we anesthetize on day to day. And it is a language everyone speaks and everyone understands. So investigations. So investigations, we are guided by NICE guidelines for pre-op investigations. So what investigations we have to do for what type of surgery and what type of grading patients needs investigations. So if we take our patient 70-year-old coming for a major surgery, we grade them as ASA 2 because he's got hypertension. So, and he is 70-year-old. So looking at the second box, you would need most of the investigations. So talking about investigation, why do we need full blood count? So we need to address to find out anemia or thrombocytopenia, whether the patient is anemic or thrombocytopenic. So as I previously mentioned, anemia plays an important role. So we need to further investigate why this patient is anemic, whether it is a iron deficiency anemia or anemia of chronic disease. So we need to optimize that. Urea and electrolytes, it gives us a baseline renal function, so which helps us guide intravenous fluid management preoperatively and postoperatively. Liver function test, it tells us about liver metabolism and synthetic function. And this helps us choose the medications. Most of our medications are metabolized by liver. So we need to make a choice or alternative planning if they have abnormal liver functions. And clotting, which is very important because many of the patients might be on anticoagulants. So we need to think about the clotting function, when to stop the anticoagulants, and think about optimizing it. So if a patient is coming for major surgery, we need to have a group and screen result to know whether they've got any antibodies. And sometimes they might need a cross match if it is a major surgery. So, and ECG is a standard requirement. If a patient has a hypertension and is about 80 years old, we need to do that. And to identify what's abnormal, if they have any abnormality, we know for the baseline. And chest X-ray and echocardiogram is optional, and it depends upon what type of surgery. So going back to our patient, so it is a 70-year-old male patient coming for major surgery. So we have done the general history, we have taken the history, we have done an assessment, and we found these numbers. So he has got a BMI of 42, and his HbA1c is 88, and his hemoglobin is 110, and his creatinine is 200 micromole per liter. And he had an echocardiogram because of his poor meds. So because he had a poor functional status, and for which we found out he had a dilated cardiomyopathy with poor LV function. So looking at each of these parameters, so we have identified this in our pre-op assessment, and the patient is not due for surgery till we optimize this, because it is a non-cancer surgery and it is not urgent. So what are the things we can optimize here? So we are guided by Association of Anesthetists of Great Britain and Ireland have come up with guidelines for blood pressure, and guidelines for diabetes, and guidelines for anemia. So this is a group of people which created these guidelines involving the general practitioners, surgeons, and the anesthetists, and involving the care of these patients. So how we go about optimization? So the optimization involves lifestyle changes. So because we identified the patient has got a high BMI, so whether we can advise regarding diet, exercise. If they have a smoking history, we can ask them to think smoking cessations, and alcohol, if they're having excess alcohol, to come down. So we can advise on the lifestyle changes, or we can refer back to the general practitioners to say that these are the things which we need to address before they come for surgery. So, and diabetes management. So the AGBI, as I mentioned, AGBI guidelines suggest that if HbA1c is above 69, they are at a very high risk of developing complications after surgery. Anemia, as I've already previously mentioned, anemia is very important because it leads to acute kidney injury, and it necessitates a blood transfusion, and which comes with the transfusion reactions or increased morbidity and mortality. So cardiac evaluation, because this patient has got a cardiomyopathy, so you will need further evaluation by the cardiologist to optimize his cardiac function before he comes for surgery. So risk stratification. So risk stratification, so we look into patient factors, surgical factors, and as previously shown in the ASA classification, and we talk about revised cardiac index. So patient factors, patient factors. So each patient ASA grade has got a absolute mortality risk. So if a patient with a ASA 3 and ASA 4, you can see there is increased risks of mortality. So nearly with ASA 4 is around 7%. So that's 7% mortality. So with the patient 70-year-old, we talked about has got severe systemic disease. So he is at a high risk as well. So we need to think about optimizing and moving this severe systemic disease patient into mild systemic disease. So that is possible only by optimization. Surgery specific risk. So we talked about the patient factor, where the patient factors involves the comorbidities. Now surgery itself has got a risk factor. So we need to think about what is the risk factor for the cardiac. This tells about cardiac risk. So low risk surgeries offer less than 1%. Intermediate risk. So most of the surgeries fall under the umbrella of intermediate cardiac risk. So that is less than 5%. And high risk surgery are like the aortic repair, peripheral vascularization. So those sort of surgeries gives a high risk of cardiac adverse event. So revised cardiac index. So it takes into account both the patient factors and surgical factors as well. So it takes into 6 factors in total. And if it is a high risk surgery, if a patient has got ischemic heart disease, congestive cardiac failure, if a patient is diabetic and taking insulin, and history of cerebrovascular disease, and pre-op serum creatinine of more than 200 micromole. So if we look at our patient in discussion, is coming for high risk surgery. With his cardiomyopathy, he qualifies for being a history of ischemic heart disease, and he's got a pre-op serum creatinine of more than 176, which is 200. So he's got 3 or more according to revised cardiac index, and he's got an increased morbidity with adverse cardiac events about 11%. So patient-centered care. So if we talk about our patient, he's got a morbidity of 10 to 15% and mortality of 1 to 3%. So we can optimize this patient and provide better care. So how do we go about this? So options. So now we have got an opportunity for decreasing the risk and making sure the complications don't occur. If we have already tried optimizing, then it becomes more difficult. So that is, we as a team, the surgeons, anesthetists, and the nurse practitioners, sitting with the patient and taking informed decision along with the patient, saying that we have optimized you, but if the surgery needs to happen, then we are taking an informed decision saying that we are going ahead with the risk only if the patient agrees. So now we had the opportunity with optimization to rehabilitate, and also by doing a pre-op assessment, we were able to identify the appropriate skill mix of the team needed for the surgery on that day. So that necessitates planning ahead and making sure the patient is not cancer. So by knowing the risks involved for the patient, we can identify where the patient can go post-operatively, whether the patient can be nursed on a ward or whether the patient needs a level 1 care where it is a monitored bed, or whether the patient needs to go to high dependency unit. So these are all the things which we can plan ahead even before the day of surgery. And with making sure the lifestyle changes and making sure optimization of anemia, diabetes, we could rehabilitate the patient much better. In summary, by taking an informed decision, patient can understand the procedure. By going through the risk assessment, we can estimate level of risk the patient is going to come with surgery, and it is more individual risk assessment rather than generalized. And we had the opportunity to optimize, and also the level of care. So we were able to identify what level of care this patient will need post-operatively, and we can plan for discharge. Thank you.
Fantastic. Thank you, Dr. BJ. Are you okay to have a go at answering some of the questions from our chat?
Yes, 1 second, sorry.
No problem. So I have a list here if you're happy to be read them.
So what happens if there are multiple contraindications to or particular surgery, but a patient needs it? As I mentioned in my talk about informed decision, yes, if there are multiple contraindications, so the surgeon, patient, and the anesthetist have to come to a conclusion, or with the patient understanding, to make sure they understand the risks involved with going ahead the surgeries. And if the surgery is not the only option, if there are other alternative strategies, interventions available, whether we should try the alternative interventions. And if there is no alternative interventions, then if there are multiple contraindications and high risk, then we need to take an informed decision that the patient is high risk, but we have to go ahead because of the surgery is important to save the life. So next, is that okay, Ollie? Yeah.
Yes, thank you. That's excellent.
Okay. What is general anesthesia composed of? Okay. Yes, general anesthesia involves, it's a broad spectrum, I would say. It is, we need to send the patient off to sleep with being monitored continuously throughout the surgery and waking up after the patient as surgery. So it needs a full talk about general anesthesia, so I will not go about explaining general anesthesia here, but it involves general anesthetic drugs where patient needs to be kept asleep so that they don't respond to surgery and they don't have any pain or sickness after surgery, and maintaining the safety of the patient throughout by monitoring and making sure they're looked after in recovery. Okay. So what's the difference between morbidity and mortality? Yes, the morbidity. So the morbidity is about having complications after surgery. So the difference is the patient will survive the operation, and after 30 days, they still might be alive, but they have got complications from surgery, because not because of surgery itself, because of their comorbidities, they are not able to withstand the stress of surgery. So after 30 days, they still be having complications because of either because of surgery or because of their comorbidities. So that is morbidity. Whereas mortality is about not able to withstand surgery and patient dies within 30 days of surgery. So that is mortality. So I've answered the questions. Is there anything else, Ollie?
Oh, there was just one more on, someone wants to know, are disorders of the HPA axis risk factors?
Disorders of HPA.
I guess adrenal disorders.
Disorders. Okay, so yeah, adrenal axis. Yes, because adrenal, so it is more specific to specific surgery. Adrenal disorders, yes, we need to know whether there are what type of catecholamines they're secreting. So adrenal surgeries are completely different, so they need a different way of looking at. So we need to measure the catecholamines, and we need to start them on infusion pre-op, so to make sure that they are safe enough to go ahead with surgery.
Fantastic. And then we have one last question, which is a very good question, which is, what attracted you to your career in anesthetics?
Oh, that's a fantastic question. I was looking forward for it. So yes, it involves patient contact every day, and it involves a multitude of procedures, which gives you satisfaction. And most of the patients we see on a day-to-day basis come to us and have a good outcome at the end of the day. So it gives us a good satisfaction. So those are the reasons why I took anesthetics as my career.
Fantastic. Okay, thank you very much, Dr. Vijay.
Thank you.
Okay. I'll share my video again then. So thank you very much, Dr. Vijay, for that fantastic session on anesthetics. Hopefully some of you, if you're interested in surgery, anesthetics is a almost dissimilar career, still takes place in the operating room, but obviously it's an incredibly high skill role. Chris, now that you're back, it would be a really good chance to answer some of these questions.
Yeah, sure.
On the
Happy
stream.
to. So I think we had a few questions from my talk in the Slack channel, so I'll just get those up. Quite a lot of you were asking for the app recommendations, so I'll post a photo in the Slack channel just before we have our lunch break, so you can all have a look at those apps over your lunch break. So we had one about our surgical core trainees and registrars referred to as Mr. and Miss, or is this reserved for just consultants? And Luxna cleared that up in the Slack channel, that once you've passed your MRCS exam, which is basically the exam you need to take as a doctor a few years down the line when you want to do your core training. And then once you pass that exam, part A and part B, then you can be called Mr. and Miss. I'll avoid the app questions just for now because I'll post something about them in the Slack. So we had a question about if your university has said that you might not be able to go to theatre because it's unsafe when you return. So I think that's quite a university specific question, and it might be tricky if that's something you really want to do to get the most out of the surgical placement when you do return to medical school. So I would say hopefully things will settle down by then and things will have changed, because going to theatre is an experience that you can't really replicate. But I think if your university is really steadfast with that and they won't let any students go to theatre, then I'm afraid that's probably you will have to sort of abide by their rules. If there's barriers like just getting fit tested, then you're well within your rights to go and do that. But if your university is being really strict with that rule, then I would say look up the app Touch Surgery that I spoke about, and also enjoy watching our talk later on from after lunch from Miss Louise Merker, where she takes us through step by step one of the procedures that she's done and recorded, and she uploaded that to Touch Surgery. So there are alternatives if you can't get into theatre to watch operations. Thankfully, people like Miss Merker have recorded their operations live so that people that want to learn about surgery can benefit without actually having to be there. So it's not a case closed sort of situation. Thankfully now there are some solutions. All right, I think I'm going to share my screen again and show you the rest of the itinerary for the day. So thank you all for joining so far. I hope you've all joined the Slack channel, because that's where you can get access to that pre-questionnaire and post-questionnaire later on. And that's where we can interact directly with you if you've got any questions throughout those talks. Hope you've enjoyed those two talks so far. As you can see, we've got a 35-minute lunch break now. Actually, just over, we're looking at more of an hour lunch break. So plenty of time to go and get some food, stretch your legs, download a few of these apps that I'm just about to post in the Slack channel. Have a little break. It can be quite intense when you're listening, and then rejoin us. Come about 5 minutes early at 1:10 British time, So I don't know what that translates to if you're around the world, but you can figure it out. And then the next talk will start at 1:15, and that is with Anna and Luan doing their pre-op surgical ward round. Following on from that will be the virtual surgery walkthrough, which is definitely one not to miss. So see you later on, and we will pause it for there. All right. Anything to add, Ollie?
I was going to say, just very quickly, hopefully people can hear me. What you will need later, and lunch is a good time to grab them, for the surgical skills session, you will need 2 mugs, which can be any 2 mugs you like. I've got one, medical student one, and a nice coffee mug. And you will need 2 shoelaces, ideally 2 that are sort of contrasted with each other. So you'll need those for the knot tying session later on if you want to tag along. Okay, hi everyone, welcome back. We're going to start the afternoon sessions. Just a few quick information governance things. We've been getting a lot of questions through about the questionnaires and the certificates. Just want to reiterate for everyone that you will have been emailed if you signed up in advance the pre-placement questionnaire. You can also find that in the Slack chat. If you're, well, obviously if you're in the Slack chat already, or if you're looking at the chat on YouTube, then you'll be able to access that and fill it out. I just wanted to reiterate essentially that one way or another, if you're worried about getting a certificate, that we will make sure you get one. You know, you guys are donating your time to be with us today. We get to talk about surgery to you guys, and we really appreciate that. So we're not gonna fiddle anyone out of a certificate, and we'll make sure that everyone gets them. A last reminder, for the surgical skills session, which takes place about 2 o'clock, you will need 2 mugs, can be any 2 mugs you like. Ideally, I guess the heavier the better, and 2 shoelaces of any color or consistency you like, where we'll do some knot tying. So this is a final chance to grab hold of those. But otherwise, I think we should get cracking, and it's a really good opportunity to introduce you to Anna and Luann, who will be taking you through our pre-op surgical ward round this afternoon. So I will hand you over to Anna.
Thank you, Ollie. Hello, everyone. So I'll start with surgical ward round. And I'll just load my presentation. Okay, so welcome everyone after the break. I hope you had a great lunch. And this session is a surgical ward round with preoperative patients. And my name is Anna Kruczynska. I'm a recent graduate of University of Nottingham. And I'll be just taking you through some cases that we hope will cover common surgical conditions, and we try to align them with a national undergrad curriculum published by Royal Society of Surgery to give you the most important kind of key information that might help you if you're a medical student, or you're doing some revision and you're preparing to be a junior doctor, or you just want to find more about surgery and you're one of the students who are on the journey to start medicine very soon. So the overview will do some common considerations when faced with surgical patients, a bit about surgical history taking, then we'll go through some cases and we'll cover those main pathologies, some preoperative consideration, and maybe just some tips from me as a medical student or starting as junior doctors, filling in what you've already heard from Dr. Vijay. And then remember, this ward round will continue after the skills session and the virtual surgery simulation in the afternoon with the same patient cases, but considering post-operative care. So what do you think are the key considerations? What things you have to have in mind when you faced with surgical patient, either in emergency department or on the ward round, you have a new patient. And this is what I came up with. So the most important thing you have to kind of determine quite early, is it an urgent emergency case or is it elective? Because this will determine what you will do next. If it's very urgent, you might decide to do very quick history and be very succinct about it and just take the most important information and fill in the gaps later. But if it's elective surgery, you have time to prepare, you have time to do many tests and ask in detail what's going on. You also want to know when was the last meal of the patient? Do you need to tell the patient, please don't eat anything anymore because I think you might go to the surgery very soon? Or you just have to have in mind, when are you going to stop their food and drink? And most importantly, medication review. You want to know what common conditions there are, what medications for those conditions need to be stopped, and what the patient in front of you suffers with, what do they take. And then once you kind of have overview, you want to start thinking of the first investigations you need to do as a junior doctor, or even as a medical student. What are those basic investigations they want you to know for your clinical exams? So in terms of history taking, I'm sure many of you know about history taking, about presenting complaint, past medical history, medications, allergies, also social history and concerns of the patient. But sometimes we just don't have time when it's an urgent case to ask in details about all those. So a good tip and very good one for clinical exams and OSCE is to have in mind mnemonic ample. You can use it for emergency cases or surgical cases that are quite urgent. The most important thing to note are allergies, because we don't want to give our patient anaphylactic shock. They already have enough on. We want to know about their medications. Do we need to stop something? It will also give us a clue about their past medical history, which is next point. Their last meal, we already mentioned that. And the events leading to the presentation. So that's your presenting complaint. What actually happened and details about it, because that will give us the most clues about what's going on. And remember your Socrates. It's a mnemonic used to talk about pain and history of pain. And today we're going to talk about general surgical cases that often involve abdominal pain. So it's very important. But even if we faced with another problem, Socrates is good for you when you get stuck. You face with the patient, you don't know what else to ask. Remind yourself about Socrates and the last 4 points, the associated symptoms, timing, exacerbations, and severity. Those are the points that are relevant to any presenting complaint, not necessarily pain, and it can get you out of trouble during exam or OSCE. And I also wanted to share the investigations. When you face with surgical patients, have in mind a structure of talking about investigations, whether it's for exams or in real life, just so you don't forget anything. Start with basic tests, bedside tests, such as urine dip, pregnancy test. Never forget pregnancy tests for female patients of childbearing age. And ECG test, because even if it's abdominal pathology, patient has upper abdominal pain, you can't be sure it's not a referred pain from the chest. Maybe they're actually having a heart attack. And ECG is such a basic test. It's very good to do this test very soon in patient's journey. And then once you consider those not invasive bedside tests, think about bloods, your basic set. And Dr. Vijay did an excellent job at explaining why we do various bloods before surgery. So your full blood count, your liver functions, LFTs, UNEs, your kidney function, CRP for signs of infection, inflammation, and group and save. And for group and save, you'll need 2 samples sometimes you might even want to order cross-match if it's high-risk surgery and you anticipate that there might be some bleeding. And you want to know clotting, to know that if the patient has any risk of bleeding, or maybe they're on medications that will stop them clotting. And then consider imaging. Start again with simple ultrasound and X-ray. Those are the common imaging that junior doctors will be able to request. And then progress to more advanced ones like CT scans. For those, you probably need senior review, but it's very good to think about them early. And now with CT scan being so widely available, it's often investigation of choice. But remember, it's ionizing radiation. So this pregnancy test is super important because you wouldn't necessarily do this CT scan on a pregnant lady or even an X-ray. So we'll start with our cases soon. So if you could join us at slido.com and enter the code, you'll be able to just follow along and answer the questions. And while you do that, I'll read the first case, and you can have a heads up on deciding the answer. So you've been asked to see a 40-year-old patient, Miss Smith, who presents with abdominal pain. It's a sudden onset pain. She wasn't doing anything specific at the time. It's in her right upper quadrant. It radiates to her back to the tip of her right scapula, so the shoulder region. And it's a continuous pain lasting more than 6 hours. She says moving makes it worse and breathing makes it worse, but it's relieved by analgesia, so slight relief if she takes painkillers. And she said that she had gallstones in the past and it's similar, but this time it's not crampy pain, it's a constant pain. And she's experiencing some nausea and vomiting, and she has slight fever, but she's not yellow, she doesn't have jaundice. And she also tells you she has type 1 diabetes, she takes statins, and it doesn't say here, but she's also on oral contraceptive pill. So what's the answer to this question? So I'll just release the quiz for you guys. So I can see many people are joining. So I'll wait a few more seconds for everyone who wants to take part on Slido to join. Okay. And you can join as we start the quiz as well. So I'll go ahead with the first questions and you can answer the questions as we go along. Okay, and you will have 10 seconds to answer the questions. Okay. So we've got acute cholecystitis and many people went for pancreatitis as well. So if we go back to our case. Okay. So let's go through the questions and explain what is more likely. So we have a 40-year-old patient. That's a common age for to get acute cholecystitis. She has pain in the tip of the right scapula, and it's continuous pain. Gallstone pain is more crampy pain, but this one is continuous, so it's less likely to be gallstones. And the pain is exacerbated by moving and breathing, so there's some irritation there and inflammation. And the pain is similar to gallstones, as we said, but constant. And she has all those associated symptoms of nausea and vomiting that are so typical of cholecystitis. But she's also feverish, so again, some inflammation, infection going on there. But the important thing is she doesn't have jaundice. So we can say that there's no blockage to the biliary tree because she didn't go yellow. There's no obstruction. And she has this past medical history of gallstones, and that will also suggest that she has acute cholecystitis. And yeah, we can move on to discuss a bit about biliary disease. So just for those who might not know, cholecystitis is the blockage of, cholestasis is the blockage of flow of the bowel. Cholelithiasis is where there are gallstones present, and cholelithiasis is gallstones in the bile duct. And different conditions will affect different parts of biliary tree. So the biliary colic will present with this intermittent right upper quadrant pain. And usually that will be because there are gallstones in the gallbladder. And those gallstones irritate the gallbladder. There might be some inflammation, and gallbladder, especially after fatty meals, will contract to release the bowel, and it will contract on those stones, and that will cause those crampy intermittent pains. And cholecystitis is when the gallbladder is inflamed, and that's usually when the stone is stuck in the cystic duct or it's obstructing the gallbladder. So the bile can't flow in and out easily, and it's causing inflammation and infection. And then we have cholangitis when we have blockage of the common bile duct, for example, and the stone is stuck there, and it's blocking the flow of the bile. And we have the stasis of the bile, which causing inflammation and infection that is ascending through the biliary tree. And commonly associated with cholangitis is Charcot's triad, which is right upper quadrant pain, fever, and jaundice. And stay tuned in, because later on you'll be able to observe the treatment of cholecystitis. So we mentioned the presenting features of cholecystitis, that is inflammation of the gallbladder. And what would you see on the investigations? You might see those raised inflammatory markers and mildly raised leukocyte, white blood cells, but you wouldn't see the obstructive picture, because there is no no blockage of the bile duct. Patient doesn't have jaundice, and the LFTs don't tend to be so deranged. So now I wanted to talk about investigations. So if we go back to our poll, what investigation would you do next? What investigation would you do first? So the first one you would do. Okay. So let's see the correct answer. Well done, everyone. Okay. So let's go through those investigations. So many of you also answered ERCP, which is great, because that's a gold standard investigations. And it's very good that you have this knowledge to know that this investigation is used. But when thinking about patient care, always think less invasive to more invasive. And in this situation, the first investigation you would do would probably be ultrasound, because it would give you some clues, and it's not very invasive investigation. So if patient can tolerate it, it's a good one to do. Let's just think a bit more about the investigation. So common ultrasound findings you might see is thickened gallbladder wall, because there's inflammation. You can see some gallstones in the gallbladder or in the ducts, or you might see dilatation of the ducts, because there is gallstone there, or there is a blockage and the ducts are dilated. And when I think about investigation, always less invasive to more invasive. So the next one that is least invasive after ultrasound is MRCP. And this investigation is useful when you don't see any evidence of stones on the ultrasound, or you're not quite sure about the diagnosis. And it uses magnetic resonance to visualize the biliary tree. And it's a very sensitive and highly specific test that you can do. The reason ERCP is a gold standard is because it's an excellent test which enables you to visualize biliary tree, but also it allows you to do intervention at the same time. And it stands for endoscopic retrograde cholangiopancreatography, because what you do is the endoscope is inserted through the patient mouth to all the way to the first part of the small intestine, the duodenum, and through the sphincter of Oddi, where it connects with biliary tree, you can inject the contrast to visualize the biliary tree. And then if you find blockages, at the same time, you can insert instruments to retrieve that stone and fix the problem right then and there. Sometimes also another procedure is done, and another kind of investigation procedure, which is called PTC, and it's percutaneous transhepatic cholangiography. And this can be used to also visualize biliary tree, but it's more invasive because you insert the contrast through the skin to the biliary tree, and it can also be used to insert drains. So that's kind of most invasive out of those. In management of cholecystitis, you'll see the operation later on, but when you have the patient in front of you, you have to think about fasting them so you give rest to the gallbladder so it doesn't contract, trying to release the bowel to help with digestion. You want to give patient fluids. They might be vomiting, or they've been vomiting before and they might be dehydrated, and you're also going to tell them not to eat things, and you want to optimize them for surgery. You might give them antibiotics if there's signs of infection, and ideally you want to remove the gallbladder, because if they already have stones and they already had one acute cholecystitis attack, they're most likely to have another one. And nowadays, it's ideally done very soon after presentation, because inflammation of this area will result in adhesion formation, and that will make it much harder for the surgeon to operate later on. And obviously, laparoscopic surgery is much safer and leads to less complication than open surgery. Okay, and now you know this patient is been reviewed by the consultant and they've been listed to have surgery very soon. And you want to think, what are the considerations before the surgery? And I know you've heard a lot about this from Dr. Vijay, but I just want to share my way of thinking about it. And I divide it into 3 ways: what needs stopping, what you need to give, and what you need to review. So things you need to stop, it's always food. And when do we stop food? We stop food 6 hours before the surgery. This patient might be already fasting, but generally that's what you would do. And you will stop clear fluids 2 hours before surgery. And what do I mean by clear fluids? Clear fluids are things like water. It might be tea, but with no milk and sugar, and you allow patients to have those until 2 hours before surgery. And sometimes you need to stop certain drugs that might interact with anesthetic, or that might lead to problems or higher risk during operation. And common ones are things like potassium-sparing diuretics, ACE inhibitors, tricyclic antidepressants, but also things like oral contraceptive pill. And also things about antiplatelets, anticoagulants, and you always work as part of the team, so do discuss this with your seniors and all doctors on the ward when you on your placement as a student, and ask for reasoning why this patient had them stopped, and if they had heparin instead, or why the doctors decided to not stop their anticoagulants, for example. And then remember things that you need to start. So patients need fluids, especially if they've been nil by mouth for some time. They probably going to be in pain and they not moving as much. So they have higher risk of forming clots in their leg. So you need to give them VTE prophylaxis. And also consider medications that they might need straight after surgery or even before surgery, such as pain relief, antiemetics, and laxatives. And important things to review and have in the back of your mind, that there are some patients that have medical conditions that require either very time-critical medications or specific way of giving medications, such as Parkinson's disease, which is one of those time-critical ones. And you might have to think of switching one route of giving medications to another, because you can't really omit their medication. And also diabetes, especially patients that have insulin-dependent diabetes, or patients that have been taking steroids for a long time. Steroids are responsible for your stress response. So if you would stop them very suddenly, you wouldn't be able to mount the stress response. And surgery is a very stressful, physiologically to the body. Therefore, we have to keep their steroids going and we have to double their dose. So keep in mind on those conditions. This patient specifically, we stopped their food, we stopped their drink. Also, this patient was on oral contraceptive pill, so that needs to be stopped. And ideally, if it was a surgery that was planned before, we would stop it 28 days before. We gave VTE prophylaxis, fluids, pain relief. And we also have to consider that she's a diabetic, and what would we do with insulin in diabetic patient? So this is just a guide, but and always look at the local guidelines. But what patients that have diabetes usually take two types of insulin, long-acting insulin and short-acting insulin. And you want to avoid glucose level in the blood going either too high or too low during surgery. So day before, you might reduce their long-acting insulin to 80% of the usual dose. And on the day of the surgery, you will keep the long-acting insulin because it's keeping that steady blood sugar level throughout the day within normal range. But you will stop the short-acting insulin because the patient is not eating. We're fasting them for surgery. You probably will also put this patient first on the list, so they're not being fasted for very long. And you will put them on variable rate insulin, so to keep their glucose level steady throughout the operation. You'll measure their sugars and you'll give them glucose and insulin according to their needs. After the surgery, we'll wait for the patient to eat and drink and be stable with that. And only after they have their first dose of short-acting insulin, you wait for a bit, 30 to 60 minutes, and only then you will stop their variable rate insulin. So diabetes is a good example where you need to do something extra for a patient in this operative period. So let's look at the case 2. So we have, you are a junior doctor again in emergency department, and you met this patient, Mary Smith. She's 21 years old, and she presents with abdominal pain. She had this pain for 3 days. It was quite vague, not very severe. And then last night it woke her up from her sleep, and it was very, very bad. It was kind of lower abdominal pain, worse on the right. And now it's very severe, 10 out of 10. It doesn't radiate, and she feels better when she stays still. If she moves, the pain is worse. She also had symptoms like nausea, and she vomited once and lost all her appetite. She feels hot and sweaty, but has no urinary or gynae symptoms. And you have some urine dip and pregnancy test on the side and some examinations. So she's lying very still, she's sweaty, pale, in pain. And when you palpate her abdomen, she has some rebound tenderness and guarding, and she has positive Rosing sign. So what is the most likely diagnosis? So I'll let you answer on our live poll. Okay, let's see the results. So most of you got the correct answer, appendicitis. So let's view the reasoning for it. So it's a 21-year-old lady. That's a typical late teens and early 20s is a typical age for appendicitis to present. She first had this vague abdominal pain. That's also very typical. And then this pain localizes to the to the right side because that's where the appendix is. So you probably heard before that the pain can start around the belly button, around the umbilicus, or often patients say it's just vague pain. They can't localize it well. And now it got really bad, and the fact that she feels better when she is lying still, it suggests that she has some peritoneal irritation, and movement makes it worse. And when you see little kids that present with appendicitis, you can often spot the diagnosis that there's something going on by the way they behave. So if they're jumping on the bed and moving quite a lot and letting you touch them, it's quite unlikely they have appendicitis. But if they try not to move and lying still, that's a very good suggestion they do. And this patient has this associated symptoms. So she vomited once, she has some nausea, loss of appetite. And she has typical signs on examination as well. So we know it's not ectopic pregnancy because her pregnancy test is negative. It's unlikely to be UTI because her urine drip is normal as well. Gastroenteritis, I would expect more vomiting and maybe diarrhea as well. She only vomited really once. That's why the appendicitis is the most likely diagnosis. But bearing that in mind, sometimes it follows a GI infection because appendicitis is inflammation of the appendix. It's when appendix becomes inflamed, and that can be because of infection, of obstruction. And this inflammation can progress because as the appendix swells up, it will cut off its own blood supplies, and then it will lead to gangrene, and then it can perforate, leading to peritonitis. And this fact that the patients had guarding and rebound tenderness, those are the signs of peritonitis because they kind of tensing up their abdomen, and it's not tensing up voluntarily, it's involuntary reaction to the irritation of the peritoneum, the abdominal cavity. And rebound tenderness refers to when you press on the abdomen and you then release the pressure, that's when it hurts more. And they also have positive Rosing sign, and that's when you press on the left lower side of the abdomen, but the pain at the time is worse on the right side where the appendix is. So diagnosis and management. Diagnosis is clinical. You can often spot the diagnosis, and if you have strong clinical suspicion that is appendicitis, you can kind of take them to theater, and you don't really need anything else to prove that it's appendicitis. You'll do tests to help you exclude other things and help you decide that it is. So you'll do urine dip and pregnancy test to help you exclude urinary and gynae pathologies. You'll do blood tests to see if the inflammatory markers are up, because they often are. And you might do other tests like ultrasound scan to help you determine if it's maybe another gynae pathology, if you can see some cysts. And if you suspect perforation, you might do erect chest x-rays to see if there's any free air under the diaphragm. And often CT scan can be done. And what do you need to do? You need to admit the patient, put them near my mouth, ready for the surgery, and do those basic tests. And then they'll have appendicectomy, and it can be open or laparoscopic. And as always, laparoscopic leads to less complications, less invasive. So that's all from me. And the word round will be continued by my colleague Luan.
Right.
Anna, are you okay to take a few questions from the chat?
Yes, but should we wait maybe till the end?
Oh, absolutely. Sorry, pardon me.
Okay, so Luan, if you go and then we answer questions for the session.
Yep, got it. Okay. Right. Hi guys. So my name's Luan. I'm currently a final year from Newcastle University, Malaysia. And yeah, I'll be taking over for Anna for the second half of the surgical ward round. So I'll be covering 2 shorter surgical cases, okay? So if you haven't done so already, you can join the Slido with the link here or through the QR code to answer the questions, or you can answer on the Slack channel as well. Right, so let's take a look at our first case. So we've been asked to see a 40-year-old man, Mr. Ahmad, who presents with a foul-smelling left foot. Now his foot has been dusky looking for a week and had only started becoming foul-smelling over the past 2 days. He is restless, and on examination, you realize that there's necrosis, which is blackening, of the 4th and 5th toes, and a 2 centimeter by 2 centimeter ulcer on the plantar surface of the left foot, so the bottom part of their foot. Sensation was not intact, and you can't feel the pulses on the foot as well. In comparison, the right foot seemed fine. He has a 15-year history of poorly controlled type 2 diabetes on insulin. In terms of observations, you realize that his blood pressure is a little bit high, heart rate is about 115, respiratory rate is about 15, temperature is at 38.9 degrees, and his SpO2 is 98% on room air. So knowing all of this, what is the most likely diagnosis? Okay, I'm going to start the poll. Is it working? Yeah. Okay. Okay. I think most of it is correct. Yeah. Oh, and guys, sorry, bit of technical issues, right? So anyways, if you clicked A, then A is the correct answer. So the reason behind A is because looking at the features, you can see that it's the most suggestive of diabetic foot ulcer. And if you look at the other options, things like cellulitis, now it's on a milder scale. So you don't really get features like loss of sensation or not feeling distal pulsations in the foot. And with critical limb or acute limb ischemia, you usually get severe pain as the main presentation. So if you're left with A and E, it's usually a debate of which one's more common. And in the UK, necrotizing fasciitis isn't as common. So chances are it's probably diabetic foot ulcer. Okay, so when we look at the pathophysiology of diabetic foot ulcer, you can really pin it down to 2 main points on how it forms. So with diabetes, usually long-term diabetics with very poor control get really poor peripheral neuropathy. So their nerves become damaged. And because they're damaged, they can't really feel very well in their feet. So sometimes they describe it as pins and needles, or even some numbness in the foot. And another problem these patients get would be peripheral vascular disease. So with diabetes, their blood vessels will go through arteriosclerosis. So there's a lot less blood flow to the legs, which contributes to very poor healing as well. So with these 2 factors in mind, when you get patients who wear really poor, ill-fitting shoes, and when they get like blisters or small cuts in their feet, these small injuries can't really heal very well. And because they can't heal that well, and because patients are less likely to find them because they don't feel pain from it, it can eventually form necrosis, which is like blackening of the digits or parts of the feet, or it can even cause auto amputation. So sometimes the toes might even fall off in really, really worst cases that I've seen. And it can form ulcers as well, as we see with this gentleman here. And a worst case scenario would be sepsis. So their foot gets infected and the patient basically faces like an overwhelming infection. Okay, so seeing as how you're the doctor in charge of these patients, you think about what initial investigations you would want to do for him. And there are three main ones that I put down, which would be the random blood glucose, Doppler ultrasound of the feet, and full blood count. Now, when you think about the rationale behind all of this, you know that he's diabetic. So naturally you want to take his blood glucose levels. You want to see whether he has other diabetic related conditions as well. You want to see how well or how poorly controlled his diabetes is. So in this particular patient, his random blood glucose is 25 millimoles. In terms of a normal range, it's actually 4 to 11.1. So you can see that this patient clearly has very bad blood glucose control. With Doppler ultrasound, it's usually used to check for the blood vessel health in the leg. And it's quite a good indicator as well, because when you do an ultrasound on the blood vessels, healthy blood vessels would actually have a little pump when the blood flows through, because it's not just your heart that's pumping blood around. Your blood vessels do a small pumping action as well. That's how you get the triphasic or the biphasic or the monophasic ones. So the more elastic they are to pump, the better. So that's where you get your triphasic one, which is a healthy sign. Whereas if you get a biphasic sign, it usually means that it's generally abnormal. But in our patient's case, it's monophasic. That means the blood vessels are stiff. So it's clearly abnormal. And if you recall with Mr. Ahmad's vitals, you recall that he has a raised temperature, raised blood pressure as well, raised heart rate. So full blood count is definitely necessary to rule out any signs of infection, particularly for any raised white cell count. Okay. So in terms of management, you know that I've put his observations down there. So as a junior doctor, you should think, what can I do for my patient at this current point in time? And I've basically pinned it down to these things. So, you know, for diabetic foot patients, generally when they come into the hospital, they need to undergo some form of surgery. The mildest on the spectrum being wound debridement. So that's basically a very sterilized way of cleaning out their ulcers and stuff to make sure they clear all the dead flesh from the foot. So you only keep the healthy flesh there. On the harsher scale of the spectrum, there will be amputation. So depending on how severe it is, you would amputate accordingly to the levels, okay? But before all of that, you have to think about what you need to give your patient at that point in time. So if you're gonna put them through surgery, you should definitely have the patient start fasting as well. And while they're fasting, you don't want them to be dehydrated, so you give them fluids. And because you're worried that he might have a superimposing infection, as you can see, his temperature is about 38.9 degrees. You want to give him antibiotics as well. And it's good to give antibiotics pre-op as well, because it helps to reduce the chances of infection. Okay. If you have any questions, I'll try to answer them at the end of the presentation. Right. So, in terms of surgery for this particular patient, we would do something called a raised amputation. Now, a raised amputation is basically a good way of saving the rest of the digits from the leg. So if let's see, okay, in this patient, his 4th and 5th digits are affected, right? So what you want to do is that you want to take away the necrotic parts. So you can't salvage these two anymore. So you want to take this away, and you want to take away the metatarsal bone. So it's like this square-ish bone at the foot, as you can see here. And you basically want to save the other 3 digits. So it's basically a way to preserve some form of function for the patient as well. A little bit niche, but it's nice to know. Okay, moving on to our next patient. We now have a 90-year-old woman, Mrs. Alicia, who presents with painless progressive vision loss from both her eyes over the past 2 years. Now, she generally describes her vision loss as becoming blurry, and she experiences starbursts around lights, especially at night. And initially, she found that wearing glasses helped with her vision, but they gradually became ineffective over the months. Her poor vision can also makes it hard for her to carry out simple chores. When you examine her, her pupils were equal and reactive with intact accommodation, so no problem there. But you cannot elicit a red light reflex. Past medical history-wise, she has a 50-pack year smoking history, hypertension, and a tonsillectomy about 50 years ago. Observations, blood pressure is at 140/85, heart rates at 89, respiratory rates at 15, temperatures at 37 degrees, and her SpO2 is at 98% on room air. So what's the most likely diagnosis for this patient? Right, try it one more time to put it on a live poll. Okay, you can answer. Okay, so the answer is cataracts. So as you can see from the features, it's generally more descriptive of cataracts. Now, we can just go through the list of the options, okay, to rule them out. So with hypertensive retinopathy, the way it presents is that usually patients come with really high blood pressure. They might lose their eyesight quite suddenly, or like very gradually, but the way the vision loss happens is very different from how it's being described here. So we can rule that out. And I think it can be similarly said about age-related macular degeneration and chronic simple glaucoma. The vision loss you get from it starts from the periphery. So if you imagine it as a circle, it starts from the outside and it kind of gradually deteriorates towards the central point over time, which is not what's happening with Mrs. Alicia. And with iritis, one of the key ways that questions like to ask would, when they describe iritis, would be photophobia, but she has no problem with that. So we can pretty much rule that out as well. Okay, so it's C, cataracts. Now, when we look at cataracts, it's basically a disease of the old age. Yeah. What happens is that over time, the lenses in your eye becomes cloudy. And that's because the protein fibers in your lenses, so they're made of water and protein fibers, right? But the protein fibers, they kind of clump together over time and it causes your lens to become opaque. So if you imagine a clear glass versus an opaque glass, with a clear glass, it's easier to focus light on a single point. And that's why eyesight tends to be clear. And if it's opaque, the light's refracted everywhere. So you can't focus your sight on one singular point. That's why your eyesight turns blurry. And also because with how the protein fibers clump together, they harden and they thicken. So when your eye tries to have that flexibility to bend the lenses according to the distance of the object, it doesn't bend very well. And that also contributes to that blurry eyesight you get with Mrs. Alicia. Okay, so what initial investigations would you do with her? So I've pretty much come up with these ones. Now, for a fundoscopy and a slit lamp test, honestly, for cataracts, it's not necessary to use them. Because cataracts can be diagnosed clinically, but if you want to rule out other eye conditions as well, then you will probably go through these tests, okay? And since in her particular case, we want to send her for surgery, for a lens replacement surgery in particular, so we need to get her baseline counts for things like her glucose levels, her C-reactive protein as a CRP, a full blood count, make sure she has no signs of anemia or any blood problems that you should know about, because that's very important if you want to take patients to surgery. You should know that she has no signs of infection, etc. And you want to assess her fitness of surgery as well, because as you remember, Mrs. Alicia is 90 years old, so we want to make sure that she can withstand the surgery as well, even if it's a minor procedure. Okay, so as I've already said with her, she needs a lens replacement surgery. A bit of a disclaimer here. Technically, the first line management for cataract patients will be a conservative management. So that means they'll be prescribed like glasses, maybe they'll ask them to read in like brighter light, but if it starts affecting their daily lives and they can't go through it very well, then usually that's when surgical management is indicated for a lens replacement surgery. And because you know that she needs to go through surgery, right? So she needs to fast as well on that day, and you need to give her fluids so she doesn't dehydrate, especially given her age, right? So I think that's the end of my presentation. If there are any questions, please let me know. And I'll hand it back to Ollie.
There were just a couple in the chat, guys, that you might want to address. Someone was saying, why might you choose to perform an open appendicectomy over a laparoscopic one?
Okay, so I think this one is for me. So there might be many reasons, but if you present it with the patient and if you have a suspicion that appendix already perforated, that is kind of an emergency, and that's one of the situations why you might need to do open surgery and then a washout of abdominal cavity, because in that case the content of the appendix would be released and all the fecal matter and pus would be released into the cavity. And due to urgency of this, open surgery would be indicated. Also, sometimes laparoscopic surgery, if something goes wrong, might be converted to the open surgery. So those are the two common indications.
Okay, and someone else has asked, I can't see it, but someone definitely asked what the purpose of the appendix is, its biological role.
Okay, so there are few theories about this, but it's kind of remnant, and in other animals we know that it's bigger, but in humans we think it plays a role in immune response and regulation of the gut in that way. But yeah, there are many theories about that.
Okay, fantastic. Thank you so much, guys.
Any more questions for me or Luan?
I think.
Oh, someone has asked, would Ray's amputation, I guess that the patient in the diabetic foot case, would that foot confer the same level of balance as a normal foot?
So obvious to me and from my experience, no, because you technically need most of your digits to have full balance of a normal foot. So it can never really regain that same level. But as compared to taking away the entire foot versus taking away just 1-2 digits, it will confer more balance. If
I could weigh in on this one.
Yeah.
Sorry to interrupt you, Luan, but that's a really good question, Tusha. I actually had a case a few weeks ago where I was on a night shift, called to see a patient in the night who had had an amputation about 3 or 4 days before. It was a below knee amputation, and he also had problems with his prostate. He needed to go for a week more regularly than you or I. So he was really struggling to manage going for a wee whilst having his new absent limb. So he actually had several falls and damaged the stump that was formed on his where his below knee amputation was. So I think the real key to point out here is that physios and occupational therapists are vital for recovery of any amputee patients, and they play a really important role to giving that patient confidence on how to use their new limb and getting used to it.
Yep, definitely.
Thank you. And then there's one
Thanks,
on the
Chris.
YouTube chat from Shraddha. Forgive me if I'm not saying your name properly, asking if someone presents in A&E, how might you decide if their abdominal symptoms are medical or surgical?
Okay, so it all goes back to presenting complaint and what kind of things they present with, and this presentation will guide you on what further tests you might need. And often also the past medical history will help you. So let's say someone has abdominal pain and things like guarding and things that rebound tenderness, all those things that kind of suggest the peritoneal irritation will give you clues that they're more likely to be surgical. And you have other tests to help you. You can also request additional scans that on X-ray that will help you determine if it's something that you can help with medications or you need surgery. And with any condition, remember your structure, that you always try to give some conservative treatment, then you go with medical treatment, and then you move to surgical. So in many cases, you will try to give them some symptomatic relief and then medication that can help. But if it's a clear surgical presentation, you might not try that first. You then will go to theater. Like in the case of appendix, in that case that I presented, this appendix looked like there was some guarding and like at least local peritoneal irritation. So in that case, you wouldn't wait. You would just remove the appendix to prevent it bursting.
Fantastic. Well, thank you both once again, and we will move, if it's okay with you guys, into some surgical skills. Now, fingers crossed. Look at that. Set up a view from above here. So this is Ollie speaking again. I'm a final year student at Warwick. I've just entered my final year of medical school. I've got a mock surgical table in front of me here. Now I'm really going to be relying on the chat. I've got it open, guys, so if you have any questions or feedback on what's going on, now more than ever, I would really appreciate it from you. So we're going to start just by talking through some of these instruments, because if you go into theatre for the first time, you might be wondering what these things are. You know, some of them kind of look familiar, some of them kind of don't. There are particular ways to hold and use each one. And if you are scrubbed in, sometimes you might be asked to hold particular instruments or to use them. So the first and perhaps most obvious one here are just a pair of scissors. These look like normal scissors and they are normal scissors. These ones are curved. Sometimes you see straight ones, and they are as simple as they sound. They are used for cutting various things, whether it's tissue or for cutting suture material, for example. You then have these, which look like scissors, but are not scissors. These are what are known as needle holders, even not forceps. So it's tempting, just as you would be tempted to normally hold a pair of scissors like this between your thumb and middle finger. It's very tempting to want to do this with needle holders. However, the correct way to hold these is with the ratchet mechanism in the middle facing towards you, your thumb through one hole, your ring finger through the other, and then your middle finger to stabilize the instrument like that. And then finally your forefinger comes and sits here close to the edge. or close to the distal end of the instrument. And the reason that we do this is that when we're tying or trying to do anything with the instrument, in fact, gives you much more fine control over where the end of the instrument actually goes. So you can see if I hold it like this and I'm trying to control where the edge goes, I have much, much more control if I'm using my forefinger to stabilize the instrument. And I did say that there was a ratchet in the middle, which you can see here. So when I lock the two sides together, you can see that they now won't come apart unless I manipulate the two halves of the ratchet to come apart. Someone's asked in the chat, I can see, is palming the needle holder acceptable? I was told off, and I think it depends how you learn. Some consultants like it, some consultants don't like it. It seems to be associated with particular specialties as well. But the reason why that's important is that if I just go to, just pick up my suture here, this isn't mounted properly, but you can see that the suture needle, you can see there, is clamped into place within the needle holder, and I can't physically let go of it unless I move my hands such that the needle is released. So it gives you lots and lots of control over your needle. And then the other two instruments that I've got here are two types of forceps, which I guess just look like tweezers. And we have two, trying to show you the difference here. These are what are known as non-toothed forceps because they don't really have teeth, they have flat ends. And these ones, hopefully you can see, have pointy teeth. And the reason why you might decide to use a particular type of forcep is that these non-toothed ones are less traumatic for tissue. So if you're working on very fine tissue and all you need is traction on the tissue, then you will use the non-toothed ones. If you're working on more dense tissue, such as doing skin closure or abdominal fascia, or deep layers of tissue, then you will use the toothed ones to get more grip. And just a word on instruments before we continue, because on my last surgical placement, my consultant did something to, I think, teach me a lesson about theatre etiquette. And as Chris said in his fantastic talk this morning, behaving yourself in theatre and obeying the rules is really important because it can be a stressful environment and there are lots of codes of practice. And the surgeon said, I was scrubbed in watching the surgery, and he said, Ollie, can you reach over to sister's table and get me the clamps, these clamps for holding intestine? So I reached over to the scrub nurse's table, having been instructed to do so, picked up the instrument off the sister's table, who immediately proceeded to take it off me and then whack me very hard on the back of the hand with it. Golden rule, you do not pick up anything from the instrument nurse's table because they need to know where everything is at all times. And even if someone asks you to, you always ask the nurse before you take anything off. So a very quick word on sutures. I've got two types of them here. Got a very small one here and obviously a much larger, more menacing looking one here, which would be used for closing larger wounds. I've got two different types of suture packet here. We have a monofilament here in my right hand and a braided one in my left. So a monofilament, as it sounds, is one string, if you like, attached to the needle. And this one, the braided one, is, well, braided, as the name suggests. It's several strings wound around each other, much like you'd make a rope. And there are different reasons why you might want to use different types of suture depending on exactly what you're trying to achieve. And the only other thing to say is that some sutures are absorbable and some are non-absorbable, so they will stay in the skin. If you've had wounds closed, you might have had non-absorbable ones placed in. So for example, in the emergency department a few days ago, we had someone with quite a severe forehead laceration come in, and I was the one who ended up suturing her forehead closed, and we used non-absorbable sutures for that. So she went home, and then the nurse at her local GP practice would remove those sutures later. So now that we've done that and we've got used to what some of these instruments are, how to hold them, same with scissors, by the way, you'd hold them in that modified way between thumb, ring finger, middle finger to stabilize, forefinger to point them where you want. For those interested, I think it's useful to think about Latin for the names of all our medical gear. It comes from the Latin word suture, comes from the Latin word sutura, which means to sew something, to bring together. And right, now we're going to actually do some knot tying. So I asked you to get 2 of your favorite mugs and some shoelaces, because we're going to have a go at tying some knots together. So as I said, sometimes as a student, you will have the opportunity to help close wounds, whether that's suturing or helping to tie or whatever. And all I need you to do is, as I'm doing here, take one of your shoelaces, string it between the 2 handles of your mugs. And what we're doing is we're making 2 edges of an approximate wound. So I've just passed the 2 ends, wound them round and round and round the mug handles. Then I'm going to just tie these off in a simple knot. I don't lose hold of them in these gloves. Like that. Move the knot to one side. I'm just going to give you a couple of minutes to do that. And what we've got here is a makeshift wound, where this is the inferior edge of our wound. This is the top edge. I can show you, trying not to get a Sharps injury in the process, that essentially what we've made is something like this, where this edge is this edge of the wound, top edge is the top edge of the wound. Just while you're doing that, I can see on the YouTube chat, some people are asking, can you offer to suture in theatre, or is it better to wait for your consultant? As with anything, it's usually better to wait for the consultant to offer. You've just got to get a feel, I think, for what the consultant likes or doesn't like. Anyone else in our Zoom chat, I'd be very happy for you to chime in on that. But in my experience, it's usually been better to wait for the surgeon to ask, although you can always say, you know, I've done a suturing course, or I am happy to suture. But Chris, I can see you.
Yeah, I'll chime in there. I think this really all comes from developing your relationship with other members of the team. And as I mentioned, you know, there's no use going on one ward round because you won't get to know the team. So that all comes from going to theatre numerous times with a consultant, and then they sort of slowly develop trust in your abilities, and you know, they might offer you to suture once, and they'll see that, you know, you're capable and you have had some practice, hopefully. So from that point onwards, you'll start to get a bit more responsibility given to you. But always wait to be invited.
Yeah, definitely. So particularly if it's the first time you're meeting a particular surgeon, you know, a registrar, a consultant or whatever, don't go in guns blazing trying to do everything. It can be a bit antagonistic, particularly as they have no idea who you are or your level of skill. Particularly at the beginning, always wait to be invited. And then if they like you and they think you're dedicated, which you demonstrate by showing up to things, going to teaching, getting to know the team, then you will have a good time and probably be asked to do things. So now you need a second shoelace, and I've got this very jazzy one donated by my housemate, so thank you. What we're going to do, just to set ourselves up, is you want to pass this shoelace under your makeshift wound. This is to simulate the needle having gone into one side of the wound, having come out the other side, and now we'd be trying to tie off our suture to stop it from slipping and staying in place. And there are a few different hand movements that we need to get used to. Oh, if I don't knock my setup, that we need to get used to, but we'll try and make this as simple as possible. Please feedback in the chats, guys, because this is a practical skill. I can't see you guys. Hopefully you can see me and you'll be able to follow along. So you can see that we've got the two free ends of our shoelace. One is on the top side of the wound, one is on the bottom side. I'm just going to put the bottom side over here. So now I've got the top side. You need to take your left hand. I am sorry if you're left-handed. You can try and mirror this if it's more comfortable. You need to take your left hand, thumb up in the air, and first two fingers out like you're making a kind of gun sign. Then what you need to do is bring your shoelace over the top, and you're going to grip it between your thumb and your ring finger, with the top end trailing over the top of your two extended fingers. So just so you can see that from every angle, I've got my free end gripping it between my finger, my thumb and my ring finger, going over my top two fingers. You then need to take in your other hand the free end, but it can just be further down the thread. You don't have to be holding the end. And all you're going to do is take the other side of the thread that's come out the bottom of the wound, and you're going to pass that up and over your two fingers. So just so you can follow the thread, we've got the top free end going around, coming under the wound, and then over my fingers. And then all you need to do, and I'll do this really, really slowly, is we're going to bend our middle finger. So you can see that the thread is kind of in the groove of the distal part of my middle finger. We're going to pull it around like that in front of the thread being held by my left hand, thumb and ring finger. I'm going to do that again. So I'll just release the pressure here. So once again, we've made a loop around our top and middle finger. I'm going to bring my middle finger round and grip. So we're forming a loop like that around the middle finger, and you need to grip with your left hand, forefinger and middle finger. You need to grip the thread that's going between them. You can let go with virtually everything else. Then all you need to do is rotate and pull the thread through, just like that. And we've got the beginnings of a reef knot. Essentially, any of you that spent any time in guides or scouts or anything like that, you've got an overhand knot. So I'll just do that again from the beginning. So we'll reset everything to how it was. We've got one loop above the edge of the wound, one loop below. Going to take the top thread, make a gun with our left hand, pull the thread over our first two fingers, gripping the free end with our thumb and ring finger. So you've got hold of that nice and securely in your left hand. Then you take the other part of the thread coming below the wound in your other hand, pass it upwards over your first two fingers on your left hand. Then we're going to do that movement again with our middle finger. So I'm going to bend, hook the thread, come behind, and then push. So again, do that slowly. Up and over, middle finger, pulling behind, bringing your middle finger to the front. Then I've got hold of the thread here between my first and second fingers, and we need to pull that through just like that. And then you can see how that's brought the edges of the wound together. Now, hopefully that makes some form of sense. So now we're going to do the second part, a different type of throw, but a similar idea, just in the other direction. So that was what we do with our left hand. We now need to do with our right hand. So we need to form a different shape. You're going to put your thumb and index finger together, like you're making an OK sign if you were diving or whatever. You're going to pick up the bottom part of the thread and grip it between your thumb and forefinger, just like that. Then you're going to bring it under your latter fingers like that. Okay, so the thread's going down behind our fingers and under the wound, just like that, if that's easier to see. You're then going to get the top part, the top free edge of the thread, hold that in your left hand, and you're going to bring that down over your middle finger. So whereas before we took the thread up and over our middle finger, we're now bringing the top thread down over our finger. So you've got hold here, you need to make sure you've got it really tight in your thumb and index finger. And then we're then going to do the same thing again. Hopefully I can illustrate this for you. Bring your middle finger, hook and in front, just like that. And then you need to bring it through. Don't worry, I will do this again. And there you can see we've got a throw going in the other direction. I'll do that very quickly again for you. And don't worry, guys, if you're finding this difficult or frustrating, we're going very, very quickly. And when I was taught to do this, I felt like the stupidest person in the room because I was like the last person to get it. So really don't worry, it's just a case of practice. So once again, OK sign, holding the edge below the wound between your thumb and index finger, keeping these fingers nice and straight, oops, and bringing the thread under. Then take the other edge of the thread from the top part of the wound in your left hand, bringing it down over your middle finger. Bring your middle finger behind. Again, clamp the string between your forefinger and middle finger. And then we need to rotate and pull through like that. And essentially what this allows you to do is, I'm just going to show you this to skim very quickly. When you're tying your sutures off, you'll see surgeons go one way, then the other way, then the other way again, and this just locks the sutures in place so they don't slip or come out. So normally this might be done with instruments or with your hands, depending on exactly what you're doing. You do your first tie, so that was going that way. You then get your second one, bring that through. You then might go the other way again. And you can see that I'm being a bit lazy with it here, but once you get used to the motion and you know what you need to pull through, you eventually just build this reef knot pattern. And then very quickly, and obviously this would be very, very secure. This wouldn't come off. So we're adding more and more throws on top of a reef knot. Then the last thing I'm going to show you is what's called a surgeon's knot, or a double overhand knot, which is a slightly more secure version of what we've done. And again, I apologize for the speed at which we're having to go through this. But I hope you enjoy it nonetheless. Is that we can combine our two hand positions that we've learned. So this was the left hand one, make a gun, hold there. So you hold that on one side, then you need to be a little bit manually dexterous here. So you can see I've got the same on the other side, going that way. So going underneath my fingers, under the wound, up and over like that. All you're going to do is take your right hand, hook it just like you did before, over the middle finger, and then hook up here like this. So I'm sure you can guess what's going to happen now, which is that our middle fingers on both our hands are going to hook round, and you can do it one at once if it's easier for you. So I've hooked there, done the same down here, and then you just need to pull, assuming I don't lose the thread here, everything through, and then you can see we've got our lovely double overhand knot that's got an extra throw in it. So that's a really nice and secure knot. Now, I hope that was okay, guys. We're all out of time. Would anyone like to quickly chime in who was sutured in theatre before about the type of knots that people like them to use? This is what's worked for me so far, doing suturing in general surgery, neurosurgery, and in the ED. Or if there are any questions about anything that we've talked about before we move on to our virtual surgery session. Chris, Anna, Luann?
You covered it really nicely.
Oh, do it once.
Chris, do you want to go first?
Yeah, I think thank you for that, Ollie. That was incredible, and I hope people can go back and watch that however much they want, because that was a really fantastic lesson, and shows you that you don't need expensive equipment to be able to practice these skills. So I think, just reiterating on from what Ollie's shown you there, there's the overhand knot and the surgeon's knot, and they are just the fundamentals. If you practice them, you'll be, when you do go to theatre, you'll be, way ahead of anyone else that hasn't practiced. So that will fill you with confidence. If Ollie's pretty much done, we're ready to move on to our live surgical walkthrough. Sorry, I shouldn't say live because it's actually pre-recorded. We pre-recorded it yesterday, but this session is a recorded intraoperative laparoscopic cholecystectomy, and if I can share my screen with you guys now, I should be able to get this up. So, okay. So the next speaker is Louise Merker. She's a general surgery registrar in the Southwest. So I'll hand over now. Is that clear? Can you hear the footage?
Can't see the footage on screen, Chris. Just hear it.
Okay. Just bear with me a second. Here we go. Sorry, it popped up in a new tab, I believe.
Just while Chris is getting sorted out, very quickly, a lot of people have suddenly started asking, do you get taught this in medical school? Is it something you need to practice? I don't know for you, Chris. For us, suturing isn't really a compulsory skill. You get taught it, but we're not really mandated to do it.
Okay, maybe I can just comment on that one.
Yeah, please do.
So at Nottingham, what we had is that for your early clinical placement, when surgery was part of this, some sites have been taught how to do suturing and not tying, some didn't. Often students just attend like afternoon clubs with scrubs, for example, when they learn how to do those skills. And what happened later on in advanced clinical placement, we had like a MAC assignment where we had to show that we can do basic suturing, but knot tying wasn't a big part of it. You had to tie the knot in order to complete the suturing, but knot tying wasn't a separate assessment for us. So it was kind of assessed, but it was taught very late in medical school. So if you're a pre-medical or early medical school student, don't worry about it, but you'll be just ahead of your peers if you learn it from this video.
Yeah, can I just jump in real quick? Last one. I think even if you don't have like a club, like a surgical club and stuff to organize workshops, it's always worth asking your lecturers who are surgeons, or even like lecturers who know how to suture, to organize them for you, because that's what we did for our uni as well. And that tends to be quite helpful.
All right.
Okay, so the next speaker is Louise Merker. She's a general surgery registrar in the Southwest, so I'll hand over now.
Hi, yes, Chris said, my name is Louise Merker. I'm an ST7 in the Southwest, and I'm going to take you guys through the actual operative part of a laparoscopic cholecystectomy. So this is just sort of standard operating theatre setup. You've got your patient bed, you've got your anaesthetic machine, and then you also need for a lap chole your laparoscopic stack. There's various different brands. This is the one that we have where I work. And then you need your assortment of laparoscopic instruments in your camera. So you bring your patient around to theatre, get them put off to sleep where they need to, get them positioned on the bed, and then you're about to put the ports in to start your operation. So this is a video of a real life lap chole. It was for a 35-year-old lady who had acute biliary colic, actually, not actually cholecystitis, which you'll see during the video. And if I just start it up, so the ports have already been put in. You can look up the positions, but you tend to use 4 ports, 1 for your camera and then 3 for your working instruments. And what we're doing here is we're just starting off dissecting out the lateral wall of the gallbladder. We tend to start on the lateral wall because it's the safer part of the gallbladder to work with. There's less major structures that you might encounter. Medially, you've got your cystic artery and you've got your common hepatic duct, which at the moment, as you can see, aren't clear where they are. So laterally, it's easier to start off the delineation there. The little line that you can see here at the bottom is something called Rouvier's sulcus. Anything below there, you're at risk of injuring the duodenum or the common bile duct. So we always start above Rouvier's sulcus, and we tend to hold the gallbladder. If it zooms out, you'll see it's something called Hartmann's pouch. So that's typically where most people start off their dissection. It's at the level of Hartmann's pouch, just above Rouvier's sulcus. So as you can see here, we're using the hook diathermy to do the dissection. It's quite a useful instrument to start off with. The gallbladder dissection should be quite precise with the depth, the amount of heat applied. And you're just using it to peel off the peritoneal coverings of the gallbladder to expose just the pure gallbladder tissue. I just speed it up a little bit. And once you've exposed the lateral side, you then come across the front of the gallbladder to the medial side. So you're aiming to dissect out something called Callow's triangle, which consists of the cystic duct, the inferior edge of the gallbladder, and the common hepatic duct. And then you're also aiming to obtain something called the critical view, which is different to Callow's triangle. And the critical view is where you want to have your hepatocystic triangle free of all the fat, which is what we're trying to take off here. And you want to have your cystic duct exposed, your cystic artery exposed, and again, the lower third inferior edge of the gallbladder free from all the fatty tissue. So you can be sure that you're only taking the cystic duct and cystic artery when you finally remove the gallbladder. So we're just coming up the medial side now to help define the cystic artery. You just get the impression that this is the cystic artery here, which is why we're just being very careful to take off the overlying fat coverings. And this is sort of what we describe as Hartmann's pouch, as I mentioned earlier, which is a good place to hold the gallbladder to then move it from side to side in the mobilization. This structure here at the bottom, that's your duodenum. Lots of people are often surprised at just how close the small bowel is to the gallbladder. You do have to be careful because all of these instruments conduct quite a lot of heat. So you can often cause an injury sometimes without noticing it, not because you've deliberately touched that area, but just because the heat's transmitted through. You're holding the gallbladder with an instrument called a Johann. They're quite good. They're a blunt grasper. They're used an awful lot in most laparoscopic surgeries. You can handle bowel with them, you can handle the gallbladder with them. The instrument that we're using at the moment, that's just called a Maryland. It's a type of grasper, but it's got a pointed tip, so it's good for sort of pinching the tissue and being very accurate. And it's also blunt, so we can push it in and spread like we're doing now to free off all the fatty tissue. You can also attach heat to it and put heat through it in the same way as you can with the hook. I'll just slow it down for a second just to talk it through. So here, these are all just peritoneal folders, and these are what we're trying to take off. This here is your cystic node of Lund. It's a common feature seen in most of your lap choles. And now that we've done some dissection of our tissue planes bluntly, we're just moving back to using the heat, the diathermy dissection with the hook there. So here at the bottom is where you typically find your cystic duct. And then, like I said, this part here is just us trying to dissect out the cystic artery. And what you're aiming to create is a little window free of tissue, which is your hepatocystic triangle here in the middle. Yeah. Now, the reason we're so cautious about identifying Callow's triangle and obtaining your critical view is because we generally think of a laparoscopic cholecystectomy as being quite a benign operation, but actually the gallbladder sits near some quite major structures. And the one everyone worries about is your common bile duct or your hepatic artery. Because if you accidentally think that that's your cystic duct, your cystic artery, and you clip it off, then you can cause some quite significant problems. A bile duct injury is actually quite a morbid thing for a patient. And 20% of your patients that get a bile duct injury will actually die within 5 years and complications related to it. So it's quite serious. That being said, they do happen, and it's actually just about recognizing it early. That's what you've done, and then discussing with your local HPB centre about how you think best to fix it. So here again, we're still just defining out this triangle here. Removing all this fatty tissue, because this here will be our cystic duct, and over here is our artery. You can also use the hook for the blunt dissection by not putting any heat through it, which is what we're doing here. Just try and speed it back up again for a bit. We've decided that we just need a bit more mobility on our gallbladder, so we're just going to take some more off that lateral edge. Great, so as you can see there, we've come through now, so we've got a safe window. If I just slow it down again to point out some structures. This here will be our cystic duct. Now we just need to properly define our artery so we get that critical view prior to applying our clips. The common hepatic duct is probably here within this band. And as you can see, that is the Rouvier sulcus I mentioned. So as long as we're above that level, we shouldn't be in danger of injuring that. It's quite funny when you watch laparoscopic surgery, because I think you make an assumption that it's really easy, or I definitely did when you first watch it, and you wonder why people are so slow. But then when you're actually doing it yourself, you realise you're taking tiny pieces of tissue that are actually quite significant distances away from you, and getting a depth perception takes a little getting used to. The reason why you try and clear so much fat off the duct is to make it as thin as possible, so your clip is likely to stay on and not slip off. If it was to slip off, then you can get a bile leak, and the patient can get very sick. They need to come back to theatre for a washout or have a drain put in. It's just the ascending colon there. And just see it back up again. That's just quite a good view of the anatomy. So you've got your liver, your duodenum below. And as you can see, this here is your artery with this cystic node of Lund sitting on the front. So we're just defining that out now to be sure that that's what it is, and that it's not the hepatic duct or the hepatic artery just pulled over to trick us. This lady's had quite a few attacks of biliary colic, so her tissue is quite sticky, which is why we're having to use a bit of blunt dissection to get it to really come loose. So we're just cleaning up the tissue in that window at the moment, making it as wide as we possibly can, so it's as safe as possible. So I'll just slow it down for this part. So that's something called a hemalock clip. And those are what you use to seal off your cystic artery and your cystic duct. They're just plastic clips that you put on with the clipper plier, and then you just close them behind and you can feel a click. They're really safe. The other option that you might see when you go to theatre is people use metal clips. The criticism of the metal clips is you have to squeeze them shut and they only seal one end, so they could easily slip off. where these properly lock in with each other. You can remove them yourself using one of the Marylands, but they are unlikely to come off by themselves. And most people tend to put 2 onto the artery and 2 onto the cystic duct, oh sorry, 3 onto the cystic duct, but leave 2 clips inside. And that's again to try and avoid the bile leak that we discussed earlier. Just speed it back up again. I just didn't want to put that clip on. So at this point we've cut nothing, so you could stop the operation and the gallbladder would survive and you wouldn't have caused any damage if you were unsure about your anatomy. And I think that's the most important thing with the laparoscopic cholecystectomy, is it's one of the parts of the body where the anatomy of where the cystic duct and cystic artery arise from can be so variable. So that's why it's really important to make sure that you have your critical view and you definitely have dissected out Callow's triangle before you clip and cut anything. So these are just some laparoscopic scissors here. They look very similar to the Maryland, but they're sharp. Your scrub nurse should keep them very separate so you don't accidentally put one in and think it's the other. So now we've dissected our artery out the way. We're just going to focus on our cystic duct. As you can see now, the problem is the gallbladder is just very floppy, so just making sure the assistant's definitely gripping onto the top and pushing up to give us. Just taking off the final layers of fatty tissue there to make our duct as thin as possible. As you can see, the gallbladder is already going a little bit grey in colour, so you know that you've taken its main blood supply. Just squeezing the cystic duct there to make sure there aren't any stones in the duct before you clip it. Because if you clip it with a stone in the duct, the patient can still get pain and they can still get biliary sepsis, and that will need to be fixed with another procedure, an ERCP, which can be quite tricky and has got a mortality associated with it. Some patients who might have slightly deranged LFTs, at this point some centres would do a laparoscopic ultrasound of the common bile duct just to check there aren't any stones in there, and that's an alternative to doing an MRCP and an ERCP. because if you did do the ultrasound at this point and you found a stone, then you could do a common bile duct exploration to remove it. So you can see the 3 Hem-o-lok clips have all gone on. I'm just going to cut in between, leaving 2 on the stump. There's just some bile coming out there, if you can see. Great. Now you've divided your 2 structures that adhere your gallbladder in, and you now just need to take the rest of the gallbladder off the cystic plate or the gallbladder fossa. Again, you tend to do that with diathermy. And the main principle with this is to stay on the gallbladder and not dig into the liver, because that obviously can cause bleeding. And again, the 2 common complications from a lap code are bleeding and then the bile leaks. So you just want to follow the plane up between the gallbladder and the liver. Again, that blunt dissection movement with the hook is just all about making sure that you're definitely sticking in the safe plane. As you get further at the top, the gallbladder gets floppier and floppier because it's less and less attached to the cystic plate. So you might need to move your position a little bit with your assistant. So before you take it off, you do just have a quick check to make sure there's not any bleeding. So at the moment, you've got quite a good way of lifting the liver up, and so you would attend to that if you had, but we haven't. Now we're just taking off the final little bits of the peritoneum. you go, it's off, it's free. And your liver looks nice and healthy there. And so now what you do is you remove the gallbladder in a bag, and that's just in case it perforates all your stones and all the bile are within the bag. Because if they're left inside the abdomen, or if it was to have accidentally perforated whilst we were removing it, you have to wash all of that out, otherwise it's an infection risk. So you tuck it in your bag, and then you can pull the bag up out the port based on this tail. Or if you've cut the tail short, then you can pull it out using a grasper. You can make the ports a little bit bigger if you've got a very thick gallbladder that isn't going to come up your standard port sites. So you can stretch it, but you just have to make sure that you definitely close whatever defect you've made in the rectus sheath afterwards, because people can get port site hernias. And that's it, that's your procedure finished. You don't tend to leave a drain. You only leave a drain if you're worried about the risk of bleeding or a bile leak, if you weren't happy with those parts of the operation. And you just need to close your 4 port sites now. And then you can get your patient off your table, wake them up. Most of these cases are done as a day case under a general anaesthetic. The more complicated ones will be an overnight stay, and that's where you might leave the drain just in case of bleeding or a bile leak. But it is a fairly routine operation. Thank you for watching. I hope it was interesting. And any questions, if you can put them on the Slack feed, the guys will answer. Thank you.
All right. Thank you very much
All right.
for taking us through that. I'll stop the recording now.
Okay, I hope you guys enjoyed that surgery walkthrough from Miss Merker. Really grateful that that she's provided us with that content today, and I hope you really enjoyed it. We can answer any questions for you in the Slack now, so feel free to pop any questions in there before we move on. We're going to have a 15-minute break following on from that session, so please feel free to ask any questions and we'll answer in that break, and then we've got a couple more sessions to go after that break. All right. I'll just share my screen again so you can see the itinerary.
Would you like a couple of the questions, Chris?
Yeah, go for it.
So the first one that I just saw was, this is a really good question, actually. When, as medical students, people are observing during surgery, what are some of the main things that medical students should be looking out for? How can they be efficient with the time?
Okay, so that's when they've already scrubbed in theatre, is that?
I think so, yeah. What should they actually do?
Okay, so it really depends, I would say, on the sort of cases that you're looking to do. As I mentioned in my my presentation this morning, you will have university expectations. So what you mean in terms of being efficient with your time depends on what you're really trying to get out of it. So if you're looking to get your university expectations done or your sign-offs done and things like that, then I would say be really clear on what those are. If you have to attend a certain amount of theatre sessions, then you can do those, and just have it in your mind, have a clear idea of what things you might want to be doing. For example, I remember in my logbook, I had to have some proof that I'd done some suturing. Injecting local anaesthetic was another thing. So just really being familiar with your university expectations can then help you to try and action those activities in theatre. Another one was scrubbing in, and I think that's really key. So getting there like 5 or 10 minutes early before you're scheduled, having a chat to the theatre staff and saying, look, it's my first day. I haven't been in theatre before, but I'd really like to have a go at scrubbing in. Could you show me how to scrub in? That, you know, you're entitled to have that opportunity as a medical student to have people teach you to scrub in. And if they're in a rush, then just say, like, it might take me a couple minutes longer, but I'd like to join and scrub in. And then from that point onwards, that opens up those other opportunities, like doing a bit of knot tying or suturing. I think really key as a student, what you can help with will be, you know, holding a camera if it's a laparoscopic case, or providing traction if it's an intra-abdominal case with an open non-laparoscopic procedure. Other things that you can do, I mentioned local anaesthetic being one job. That comes towards the end of the procedure. They'll usually inject some local anaesthetic into the wound sites, and sometimes they use things called rectus sheath catheters to provide pain relief to the wound for 5 to 7 days post-op. And you can have a go at injecting the local anaesthetic, because there's usually 2. So the surgeon will probably do the first one and just say, oh, do you mind showing me how to do the second one? Those are a few ways that you can sort of actively get involved. But, you know, it's all about developing that relationship and going back again and again. If you've got on well with the surgeon, then say, you know, what theatre list do you have tomorrow or the next day? Perhaps I can come along then if my teaching permits it. So I think those are a few things I would say.
Awesome. The next one down is, as a surgeon, do you get used to the smell of surgical smoke?
Yeah, I saw this question. I think it's like you'll have this as well. If you've not had anatomy dissection classes yet, you will definitely have this sort of same response when you come across a new smell. And yeah, the smell of burning skin is definitely something that is odd the first time you smell it, but it's something you do get used to. And yeah, I think it's just one of those things really that happens in surgery that that over time you do get used to. One tip I did learn whilst in theatre with one of the surgeons is that with cautery, so cauterization, using burning to stop bleeding or to get your way through some tissue. You don't want to add too much manual pressure when you're doing that, because that can damage other structures and cause more bleeding. So you're literally just using the heat itself and not actually any manual pressure when you're doing that cautery.
Great. The next one down is, this was someone asking on YouTube, is there a large window of time for this surgery because it's laparoscopic, or does the clipping you're doing limit your time due to lack of blood flow to the tissues?
Okay, so I think what they're getting at there is a laparoscopic case shorter than an open one, and generally speaking, those laparoscopy is used for shorter cases to give better outcomes, because having a large wound can take significantly more recovery and increase your risk of complications post-operatively and intraoperatively. So in terms of time, it can take longer to do those laparoscopic procedures because they are a bit more fiddly, getting the ports in and doing all these tasks which require a lot of dexterity with the laparoscopic tools, which would be a lot easier with your hands in an open procedure. As for the clipping, does clipping limit time due to lack of blood flow? So I think Miss Merker showed us quite nicely there that with the plastic clips, you can remove them so if you're not happy with the sighting of those clips, you can remove them, whereas metal clips, she said that you only get one opportunity really. You can take them off, but the plastic ones give you a bit more flexibility there, so that's often the preference for plastic clips for some surgeons. once you've applied 2 or 3 clips and then cut the vessel, there's obviously no easy way of returning that blood supply. So from that point onwards, as Miss Merker pointed out, the gallbladder turned grey as the blood supply was cut. So once you've done that cut of the main cystic artery going in, then that's pretty much a dead organ and you have to remove it.
Great. There's quite a few questions. It's clearly been a very interesting talk. What methods might you use to reduce chances of port site hernia?
Okay, so I don't know whether I'm qualified enough to give a specific answer on that, but from what Miss Merck was saying, it's to do with the size. And if you use a port inserting tool, then it will create a small hole just big enough for the port. And if you are struggling to remove the gallbladder in that bag, then you can use a scalpel to make that port site slightly larger to remove the gallbladder without it bursting and spilling the contents. So if you're making additional cuts, you're going to increase the size of the porthole, and that in itself will increase the risk of a port site hernia.
Okay, and then the next one is, a really good question, actually. It looks quite difficult to stay closer to the gallbladder and away from the liver when separating it from the liver wall. Do you get good physical feedback from the laparoscopic tools?
Yeah, I think, again, that's a question for Miss Merker, really, and unfortunately that was a pre-recorded session, but she did allude to, there being a good amount of feedback with the tools. And from the practice I've done in the lap sim, I can definitely say that, when you're, a good way to practice is to pick up sugar cubes with the tools, and you can certainly feel the feedback from the end of from the lap tools. So I think, yeah, she did sort of allude to there being quite a level of physical feedback, but it's a skill that takes time to develop and getting used to that physical feedback.
Yeah, we have 2 more. One's from Avani, who says, would you ever suture the duct or an artery shut instead of using a clip?
So, yeah, once again, I would like to have Miss Merker here to ask that question, really. It's not my place to say, but what I can say about that is she spoke about bile duct leaks being, one of the most profound complications that can occur as a result of cholecystectomy. And she referred to, getting your local hepatobiliary service involved if that were to happen. So, down the line, if there is a bile duct leak, then one of the ways that they can re-intervene is by open surgery, in which they might use some suturing rather than clips. I can't say, in that specific instance for sure, but that is a method.
Sure, and then the last one from Nadia we've got in the Slack channel is, how might you reduce the incidence of post-surgical adhesions? Okay,
that's a good question. So any cut that is made will heal as scar tissue, and those scars can become adhesions. So Miss Merker showed us there at the start, when she was trying to mobilize the gallbladder, that it's not a simple process, but with time and experience, you get more efficient at doing that. And the less time you spend in the abdomen and the more careful you are, the less cuts you'll need to make, and that will reduce your risk of adhesions. But it really can happen to any sort of patient. You can have someone that has an appendicectomy when they're like 12 years old, and then they'll have no other surgeries on their abdomen, but 50 years later, they might come in bowel obstruction as a result of that surgery when they were 12 years old. So often it's quite unpredictable who gets these adhesional small bowel obstructions or pseudo bowel obstructions.
And that's it on the question front.
Right, so we'll have a 15-minute break now, unless Anna wants to go straight into the post-op ward round, you want to weigh in.
I am ready to go ahead.
Let's crack on. We'll keep these guys clear.
So we make sure we finish on time.
Over to you, Anna.
Thank you, Chris. That was great. I've learned a lot from both the practical skills session and watching the surgery. Very good sessions. Well done, guys. And I'm sure all our viewers really enjoyed those sessions. Okay, so welcome again to the surgical ward round. For all the viewers who joined us quite late, my name is Anna Kruczynska and I'm a recent graduate from University of Nottingham. And what we did just after the lunch break, we did a surgical ward round and we looked at patient in preoperative period and we looked at some common cases of surgical pathologies. So now imagine that a few days has passed and you're on another surgical ward round, and now we'll be looking at the post-operative considerations and maybe some complications and what happens to patients after the surgery. Okay, so I came up with some key considerations that I think are important. So I wanted to start by talking about pain. Pain is very useful for everyone because it alerts you about that something is wrong. You feel pain to tell you that something is not working right. But in terms of surgical post-operative period, surgical recovery, it delays recovery. Because when you're in pain, your heart rate goes up, your respiratory rate goes up, and as a result, you don't breathe as deeply. And that will increase your risk of atelectasis, pneumonia, and it kind of results in the stress response that delays recovery. It also results in people being less mobile, because if you're in pain, you don't want to move, you don't want to walk around the hospital, and that will delay your recovery. So we have to make sure that we provide adequate analgesia, and mobility itself is crucial in post-operative period. Everyone who is immobilized for some period of time will start losing muscle mass. And this is very important for our elderly patients who will lose that muscle mass very quickly. And if we don't prevent this, they might go and have surgery. And after the surgery, they might not go back to the level of independence they had when they came to the hospital. So it's really important to involve the multidisciplinary team and physiotherapists that can help with regaining that mobility after surgery. And later on, you might think of occupational therapy if someone needs maybe some ongoing support at home. Also remember other medications, so not only pain relief, but things like antiemetics and laxatives. So we use opioid analgesia often in postoperative pain. And that can cause nausea, so antiemetics are very useful. And it also can lead to constipation in longer term, so laxatives can be useful as well. And then I thought about all the things that you might take into consideration when you are in the ward round and you are asked to prepare the results of blood tests and imaging, and just some few pointers to prevent you getting the completely wrong idea of what's going on. So when looking at inflammatory markers, remember that those will be raised after surgery, just because It's something unusual that happens to the body. In abdominal surgery, you're entering the abdominal cavity. In whether it's laparoscopic or open surgery, you kind of causing some irritation and inflammation there. So inflammatory markers will be raised. It just depends how much they raise and if that's sustained, whether that's something to worry about in terms of infection, or is it just normal as a result of surgery. Also remember, especially with laparoscopic procedure, you might have a patient that had acute cholecystitis and they had surgery to remove their gallbladder. And then you're seeing them in a post-operative period, and you might order chest x-ray because you think they are developing pneumonia. And you have a look at the chest rays and you check the area under the diaphragm and you notice that there's some free air. And it's very good to spot this and notice this, but remember that air under the diaphragm in post-operative period is normal, and in laparoscopic procedure, it might take even longer for the air to disappear, the gas under the diaphragm, because it needs to be absorbed. And it can take up to a week for this gas to disappear. Also, bearing that in mind, also think about things like perforation, bear that in mind, but remember that the gas can be normal. And the last consideration, fever. High temperature after surgery can help you with your differential diagnosis, because depending on the timing of the fever, there's no hard rules, but it's if the fever is there on the first day or the second day, it automatically suggests different diagnosis to when it's a week after the surgery. And here on the side of my slide, I gave you this little table that I like to remember, that first day after the surgery, if patients have some fever and maybe respiratory symptom, consider atelectasis. And that's where the airways, the alveoli collapse, and often that happens because of inadequate breathing and irritation due to ventilation during the procedure. So we give patient anesthetic and we take over their breathing, and that irritates the airways and lungs, and some small airways can collapse, and that leads to atelectasis. And a very good way of preventing it is to encourage patient to do deep breathing, and patient at higher risk might have physio that will help them with that after the surgery. If it's maybe a bit longer, couple of days, and they have respiratory symptom, consider pneumonia. If it's maybe 2-3 days and they have symptoms, urinary symptom, consider UTI. And then 4 or 5 days, consider clots in the legs. If they have some pain, swollen legs, or breathing difficulty, consider pulmonary embolism. And if it's quite a while after surgery, a week, and they maybe have some pain around the side of the where the wound is, it's more likely to be things like wound infection or abscess formation. And it's not set in stone, but it's just a helpful guide to help you remember common complications. And maybe if you remember them in order, you're more likely to get the right diagnosis. Okay, so I'm just going to go straight to the cases, but for those of you who are new to our virtual elective and virtual surgical ward round, we are answering questions both on Slack channel and also on Slido, and I'm going to share the code with you once again so new viewers can join. So that's the Slido website, and the code you can put to join. Okay, and let's go through the first case. So you are a new F1 working on your first on-call shift, and it has been a few days since Miss Smith had her surgery to remove her gallbladder. And you just received a phone call from one of the nurses looking after Ms. Smith, and she tells you that your patient is breathless and she's been experiencing some chest pain. She also has a mild fever. And the question is, what do you do in this situation? Do you go to the patient, start treatment, order investigation, or do you just ask for observation and ask the nurse to perform some bedside tests like ECG and do your A2E assessment? Or do you just ask for more information and ask the nurse to order investigations? So I'll give you some time to answer the question now on Slido. Okay. And let's go back to the case and go through the explanation now. So in this situation, what I've put as the right answer is you ask for observation and ask the nurse to perform some bedside test and then do A2E assessment. And let's go through the other answers and kind of talk through why the others are not as good. So going to the patient straight away and starting the treatment is a reasonable option. However, you probably at this point don't have your differential diagnosis yet. You don't know how urgent it is because you don't have any observations. And you really want to just know a bit more about the patient before you decide to go there straight away. And then second option, order investigations. You always want to consider ordering investigations, but again, it's probably more important at this stage to find a bit more, kind of communicate with your team, ask the nurse to do what she can, and then you can assess further. So our option C, so it's very good to ask for observation, and this patient is breathless and has some chest pain. So one of the things the nurse can already do for you before you arrive is to do the ECG. And that's very useful because you have to consider quite wide differential diagnosis at this point and things including heart attack. So it's very important to have that ECG as soon as possible. And then because this patient has chest pain, the nurse is worried about her, unless you have another big emergency, where in that case you should be probably calling your senior, you would go to see that patient and you would do A2E assessment in a very structured way to help you come up with solution. And the last answer, some people answered that. It's very good to ask for more information. However, the nurses won't probably be able to order that many investigations for you. They might ask you, you might ask them to do some, but before you do that, you'll probably see the patient first. And I thought at this stage it's really important to remind ourselves of A2E assessment. And for those of you who are in preclinical years or just thinking about medicine, that's the way we assess patients in emergency. So we start with A, which stands for airways. And at that point, you want to introduce yourself to the patient, see if they're responding to you, are they talking? Are they able to talk comfortably, or are they breathless? Are there any additional sounds like stridor? And if there's no airways, you'll do airway maneuvers. And if there's no patent airway, you'll do airway maneuvers. We're not going to really go in details to, through that, but the importance of A2E assessment is that it organized in the way with things that come first. So A things will kill the patient first before the B things. So we go in order of importance. So always treat as you go. If there's no patent airway, do the airway maneuvers and only then move on, and constantly reassess if what you've done actually helped the patient. Then we go to B, breathing, and in that section, you want to do all the things to do with breathing. So you want to measure patients' respiratory rate, you want to observe, look at them. So always start with observations. Are they struggling to breathe? Are they comfortable? You can palpate the chest, measure the expansion of the chest. Is it equal on both sides? Percuss, are there any areas that are dual? Listen with your stethoscope. And you can also measure saturation with pulse oximeter. And if the saturation is low or they're struggling to breathe, at this point, you will give them oxygen. And you might want to, if it's a breathing problem at this stage, you might want to think about ordering chest x-ray and ordering blood gas. Once you dealt with B, you reassessed, you can move on to C, circulation. And at this point, you want to assess all the circulatory observations. So you want to look at the blood pressure, at the heart rate. You want to measure their capillary refill, and you'll ideally both do peripheral capillary refill and central. So peripheral one you can do by squeezing the finger, and central by pressing your finger on their chest. And then you also want to look at the fluid status. Do they need fluid? Do they look dehydrated? And the way you can do that is looking at the mucous membrane, feeling for the skin turgor. And you also want to listen to their heart. And at this point, if you think if the blood pressure is low, or you think they're dehydrated, they need fluids, you get access and you give them fluids. But before you do that, it would be very good to get some bloods and think about the blood tests you want to order. And if it's emergency, you ideally want 2 large bore cannulas, and you give fluids. And at this point, because we on circulation and heart, if you haven't done already, you probably do ECG as well. Then once you reassess, you dealt with C, we go to B. And we look at disability, and there are 2 ways of looking at disability. And when we talk about disability, we mean the level of consciousness. So you can use GCS scale or AFPU. AFPU is the simplest one, and probably you're more likely to do it initially in emergency before you move to GCS. And AFPU stands for alert, then responsive to voice, pain, and then unresponsive. And you just allocate one of those. Is the patient alert, or are they a bit confused, only responding when you're actually talking to them? And so on. And then you want to look at other things in the same section. You want to check for their pupils, and that will be checking if they're equal, if they were active. And also another important point is don't forget the blood glucose. So you want to do the BM. And once you deal with D, reassess patient, you can then move to E. And that stands for exposure, everything else. So how I remember this is in all the other points, we explored respiratory, cardiovascular system, neurology by looking at the level of consciousness, but we haven't done the abdominal examination. So that's a good point to do it. And sometimes you might do it sooner if you already suspect that it might be something to do with the abdomen, but that's a good way to keep it in your checklist so you don't forget anything. So at this point, you want to expose patient and also look all over their body. Are there any other injuries? Is there anything you're missing? You want to take their temperature to see if they have fever, if they have any rashes that would suggest maybe some either some allergic reaction or infection. And you also want to have a feel of their legs. You want to feel their calves. Are they soft? Are they tender? And then it's also a good point to check your surgical checklist of catheters, surgical sites, so drains, wound, catheter, because those are common sites of infection. So make sure you look for signs of infections in those areas. And while you go through your A to E assessment, remember what are the common surgical complications to do with each system. So in terms of airway, the first thing that always comes to my mind is anaphylactic shock. So you might be giving some medication to the patient who is allergic to them, and they can develop anaphylactic shock and their airway can swell and they might lose their airway. But if you think about surgery, another example is in thyroid surgery. It's always very important to observe their airways and look for at the site of surgery, because thyroid is very vascular, well vascularized gland, and if it bleeds, it can then bleed into the compartment in the neck and obstruct the airway. Then in terms of breathing, B, a common complication is atelectasis that we mentioned, pneumonia, so chest infection, and also pulmonary embolism. In terms of circulation, you can have sepsis that affects circulation, or especially with maybe elderly patients who have a bit of heart failure, watch out for fluid overload. In terms of disability, again, especially with elderly patients, watch out for post-operative delirium. Patients, it's a very stressful event physiologically to the body. So elderly patients are at high risk of developing delirium at this point. And in terms of exposure, so everything else, check the wound, check the calves and the legs, because there might be some DVT, the leg might be swollen or red. There might be some infection around the wound. And check all the ports if the patient has catheter, because maybe they have urine infection going on. And if you keep this checklist in your mind and you're assessing a patient post-operatively, you can go through your A to E and look for the common complications. So going back to our first case, the lady who had her gallbladder removed, those are her results of her A to E assessment that you've done. So you know that patient is speaking to you and telling you that she has chest pain, that it's worse on inspiration. Her breathing rate is 24, SATs 93. And you've put her on oxygen. Her blood pressure is 130/90 and heart rate is 120. She has normal heart sounds. And in terms of the disability, she's fine, she's alert, pupils are equal, and her sugar is normal. However, when you go to examine her legs, her calves are hard and swollen. Okay. So I'll just, at this point, I can tell you, I'll share the next question with you. And the question is, what is the most likely diagnosis? Okay, well done. Everyone got this question right. So that was next question. Sorry about that. We'll get to it. So that's right. The right questions is DVT-PE. And I just wanted to go quickly through DVT and PE, because we learned about the surgery, but complications of the surgery are really important, because if you're going to be based on surgical ward round, those will be common things you will see. So PE stands for pulmonary embolism, and it's a condition when the blood clot forms in the pulmonary arteries. And this blood clot usually comes from deep vein thrombosis. So the clot can form in your veins in your legs, and then it travels back to the heart and to pulmonary arteries. And then it can block those arteries or smaller arteries in your lung and cut blood supply to areas of the lung, resulting in breathing difficulties. And there are many risk factors for pulmonary embolism, and recent surgery is one of the biggest ones. But also fractures, immobility, it's therefore important to keep the patient mobile after surgery, and personal history and family history of clotting disorder or previous PEs, DVTs. Obesity, malignancy, also infection, pregnancy, and hormonal hormone replacement therapy or combined oral contraceptive pill. So if you remember from previous session, we said that we tend to stop those before surgery if possible. And one of the reasons is that you're more likely to develop blood clots. And if in this case, this patient developed DVT that led to PE, and we can say it's a provoked one because there's a known risk factor, there was a previous surgery. But if none of those risk factors would be present there, another one would be kind of prolonged immobility due to long flight that is commonly used in multiple choice questions. If none of those risk factors are present, we say it's unprovoked one. And main investigations we do is ECG, blood gas, chest x-ray, and we do some scans. So CTPE is one of the scans, but it's important to determine if the lady is pregnant, because if the lady is pregnant, we might want to use a different scan to limit the exposure of fetus to radiation. And when we're not sure about the diagnosis and what investigation to use, we do Wells score, which takes all those risk factors and we just fill in the score and it tells us if the pulmonary embolism is likely or unlikely. And if it's likely, it will perform CT pulmonary angiogram. And if it's unlikely, we can do a test called D-dimer. And this test, it's not a very good test because it's very non-specific. D-dimers can be elevated because of infection, of inflammation, not necessarily the clot. However, if pulmonary embolism is unlikely, it can help us rule it out rather than confirm it. And if it's positive, then we'll proceed to do CTPA in that case. And management will be oxygen to help the patient use the rest of their respiratory reserve to the full capacity. We'll monitor a patient for complication. We can give analgesia as required. And we'll start initial anticoagulation, such as low molecular weight heparin, and then later on we'll switch the patient to long-term anticoagulation. If it's a massive PE that it's so dangerous that we need to think of other way, otherwise patient is not going to survive, then we can also use thrombolysis to try to dissolve the clot. Okay, and now we're going to move to our second case, and that's Ms. Jones, 21-year-old patient, and she had her appendix removed 3 days ago, and she's being reviewed today. And she reports that she still didn't open her bowels today, and complains of nausea and vomiting, feeling bloated, and not passing any stool or flatus. And you examine her abdomen and you notice that the abdomen is distended and you can't hear any bowel sound. And the question is, what is the most likely diagnosis? Okay, so I'll share the poll with you. So I think I clicked that before. Sorry about that. I'll just reveal the right answer now. So that's post-surgical ILS. Sorry about this question there being too soon. We'll go through the answer now. So a post-surgical ILIS is a common complication of the surgery. And the things in this case that are suggestive of post-surgical ILIS is the features of obstruction. So we have no stool, no flatus, nausea, vomiting, and abdominal distension. So she could have peritonitis. However, there is nothing about her having any fever or feeling unwell in any other way. It could be large bowel obstruction with those features, but it's unlikely in this case because large bowel obstruction, the most common reason is diverticular disease, cancer, and it wouldn't necessarily present after the surgery. Mechanical small bowel obstruction can happen, and the most common reason is, for example, through adhesions. Another common reason is hernias. And while it's possible for adhesion to form quite quickly after the surgery, in this case, it's more likely to be post-surgical ILIS. So let's go and explore what it actually is. It's a deceleration or arrest in intestinal motility, which is very, very common after the surgery. And we have the same feature as in obstruction, so complete constipation, distension, nausea, and vomiting. And post-operative ILIS, you can think of it a bit like a spectrum. Sometimes people have it quite mild, where they just don't open their bowel straight away, or it can look like obstruction. And investigations you need to do your basic investigations of full blood count, UNEs, and CRP to look for this inflammation or if there's any infection going on. And very important is to check electrolytes, because electrolyte imbalance can promote arrest of intestinal motility. And when we look back to the question, we know that we can't hear any bowel sounds. And that's one thing that is suggesting that there's no movement of the bowel, peristaltis arrested. If we would have tinkling bowel sounds, that would be more suggestive of mechanical small bowel obstruction. In terms of management, you want to treat conservatively, but if patient is vomiting and being sick, you'll put them nil by mouth. You can put an NG tube to decompress and aspirate, and you want to carefully monitor their fluid balance, give them fluids, and check daily bloods and correct electrolytes, and encourage mobilization. The more mobile we are, the more active our gut is. And remember how we said about opiates, analgesia, constipation. In this case, review that too, and try to switch to different pain relieving medications to help the bowel start moving again. Okay, so that's it for me. And now I'll hand over to my colleague who can continue with the word round.
Right, thanks, Anna. Okay. So I'm gonna start here. Okay, thanks, Anna, for the first part of the post-operative ward round. So again, for those of you who joined in late, my name's Luan. I'm a final year medic from Newcastle University, Malaysia. And yeah, I'll be covering the last two cases in our session, which will be relatively short cases. So again, we'll be answering questions on Slido and the Slack channel as well. So if you haven't already joined, please do. And we'll crack on with our first case. Okay, so looking at case 3, which is Mr. Ahmad, the one with the diabetic foot ulcer. So it's been about a week since he's had his surgery, and you're the F1 on call, and you've come to review his charts as part of your night rounds. You notice that he has some trouble breathing, and after doing a quick physical assessment, you find the following. He has a GCS of 12, a pulse rate of 140, a respiratory rate of 30, blood pressure is at 85/65, oxygen levels are about 92%, temperature is at 38.7 degrees. And after a brief examination of his foot, you see some pus leaking out from the wound. What diagnosis are you currently worried about? Okay, let's look at the pulse, shall we? If it's working, okay. Oh. Okay. Okay, so we have 10 seconds to answer this. Okay, yep, I see that most of you got it right. We are worried about sepsis. Okay, so why sepsis? For the pre-meds who don't know what sepsis is, it's basically your body's response, your body's inflammatory response to a very strong infection in your body. So it starts overreacting in that way. So you get features like drowsiness, confusion. That's why when you do your Glasgow coma score, which is what you use to assess, I think Anna has briefly mentioned in the slides, you see that it's at 12. So it's dropped from the normal 15. You can see tachycardia as well. So that's your pulse rate. Respiratory rate is high, it's at 30. Blood pressure has also dropped. So that's a very worrying sign because you're thinking, okay, maybe my patient is going into shock, septic shock in particular. And his temperature is high as well. So that's a pretty good indicator of sepsis, okay? And I think with that, like, I don't feel the need to go through the rest of it because I think you can rule out D and E immediately. C doesn't really seem like the cellulitis, less likely to cause such an overwhelming response, right? So if you suspect that your patient has sepsis, what would your initial management be if you're the F1 doctor? Okay, so I basically pin it down to two main things. The first one would be your acute management. So you do ABCDE as what Anna has already mentioned. But what I want to focus here, particularly for sepsis, would be the sepsis 6 principle, or 3 in, 3 out, for those of us who are used to this or know about this. So 3 in, you want to put in IV antibiotics to fight off the infection. You want to give oxygen as well, because as you remember, our patient had an oxygen level of 92%. That's too low. You gotta make sure that he has adequate oxygen, right? And you want to keep him hydrated as well, especially with such a low blood pressure. You don't want him to die from shock. So you give him IV fluids. And 3 out. So you get your blood cultures, so you know what kind of organism you're dealing with in terms of the infection. You want lactate levels as well to see how your patient is progressing. It's a good indicator of how the patient will progress and their prognosis as well. And you want to monitor the urine output because the kidneys in particular are very sensitive to shock. So once the kidneys go, chances are the rest of the organs will fail as well. So you really want to monitor that. Okay. So that's the first case done. We're going to look at the last case, which is Mrs. Alicia, who recently underwent a cataract surgery about a day ago. So she currently says that she has no pain. Vitals are fine. There are no abnormalities noted during physical examination. So what would you do next? Okay, let's look at the poll. Okay. Okay, mixed bag of answers here. Let's just switch it back. Okay, So the answer is actually B. So a quick note here. For cataract surgery, since it's seen as a relatively minor procedure, technically if the patients have no problems, no complications, no pain, etc., they can go back home on the same day. And yeah, you want to draw up a discharge letter since you are the F1 involved. But as an F1, you don't have the power to just discharge her like that. You need to still discuss it with your seniors. So hopefully a specialist review to come with you to see the patient and make sure the patient's all right, then only can you drop the discharge letter. If you want to observe her for another day, it doesn't make a lot of sense as well because she's fine. Plus, if you hospitalize her for one more day, she's older, she's more prone to getting more infections in the hospital, which isn't great as well. So you do want to discharge these patients if they're fine and well. So, okay, you're the F1 doctor, your consultant asked you to drop a discharge letter for Mrs. Alicia. So what are you going to do? What components do you have to include in the letter? So I've come up with 6 main chunks that you should cover. And this would be, the first chunk would be demographics. So that's when you write down your patient details, like the patient's name, date of birth, patient number, address, telephone, sex, ethnicity, next of kin, emergency contact, etc. You also want to write her GP details down. So the practice details, the name of the GP practice, the person in charge, so an identifier. In terms of hospital details, you want to write who the discharging consultant is, which department she was from, date of admission, date of discharge as well. Yeah, so very vital information there. So after you write all those, you should then include, in terms of clinical details, like the summary of the case. So you include history and examination findings, investigations, diagnosis, management complications from the disease, the procedures, when was it done, what type of procedure, any complications involved, and any anesthetic issues that you faced during her admission. Okay. The third component will be future management. So any treatments that she requires in the future, follow-ups that are necessary, any referrals that's to be done. Fourth part would be medication. So you have to include any medications she's currently on. So remember that she has hypertension and stuff. So maybe you might want to include her hypertensive medications there. If you've made any changes, then you have to include the changes as well. So you write the dosages, you write what form they have to take it in, when, very key details that the patient and probably the pharmacist needs to know as well in order to prescribe the patient the right dosages to be taken at the right time. And very importantly, you should include any allergies and adverse reactions to drugs. Because imagine not writing that, and imagine a patient actually having a reaction to penicillin. It's quite a bad effect. So you should definitely include those if they do have any allergies or adverse reactions. So if they don't, just write a short form that a lot of people use is NKDA, no known drug allergies. Okay. Then there's also a small section for the patient. You don't want to keep the patient out of the loop because whatever you've written so far, it's full of medical jargon. So the patient's not going to understand. So you want to include them in their care as much as possible. So have a little section there just to explain what they have, the key information for them, and do it in a very patient-friendly manner so they actually understand. Okay, and last but not least, you should sign off the discharge letter with your own details because it is your responsibility and you wrote the discharge letter. So you want to write your name, designation, role, grade, specialty, date completed. So it'll be something like Dr. Lai, F1 foundation doctor from hospital A, completed this at 11th of July 2020. Okay. And I think the key thing to know about writing a discharge letter or writing any form in general is to be as specific and concise as possible, because no one wants to read a 3-page essay on an overwhelming amount of information. Okay, so that's the end of my very short surgical cases. These are my references, and I'll pass it back to Anna.
Hello, everyone. Hopefully you can see my screen. Okay, so thank you all for spending this day with us and listening to our talks. Sorry, I just noticed you couldn't see me. So I have some link for my personal teaching, so feel free to give me some feedback. And now me and Luan can take some questions about our talk, if there are any. And if not, we'll wrap up. I'll just double check if there are any questions.
Someone did want to know, Anna, why might someone have a low BP post-op?
I'm sure there are many reasons why someone can have low blood pressure post-op, but one of them is that during operation, you use anesthetic and you use medications to both control, raise the blood pressure and lower the blood pressure if you need to. So it might be as a result of medication, but also in post-operative period, low blood pressure can indicate bleeding because you are bleeding out of your intravascular space. Also, you might be losing fluid to tissues. So if that happens, that could be, for example, as a result of sepsis or for example, peritonitis. So it depends also on other presenting features and how soon after the surgery. But in your A to E assessment, if someone has low blood pressure, the first thing to do, if they don't have any contraindications for fluids, it would be to give them fluids to stabilize them until you find out the reason and look for infection and bleeding as the main ones to start with. Is that all right?
I'm sure that's fine. I'm just checking the Slack channel. They did very, very well with the questions. No, it's just very positive feedback. We've got no more questions in the Slack.
Oh, great, Ollie. Thank you for that. So feel free to do my personal feedback, but don't worry about it too much if you can't. It's just for me to improve. And what I wanted to say at the end is great, thank you, and great job everyone who did talks today. Thank you for our great guest speakers, both the talk about the preoperative assessment by Dr. Vijay, and for the great footage of the surgery. It was amazing, and I think everyone learned something from it. And thank you to Ollie and Chris and Luan, who put a lot of work into this to make it work for you guys. But also to our moderators, Luxna and Nadine, who helped us along this way. And finally, thank you to Medics.Academy for organizing virtual elective that provided us with tool to organize this great event for you. Lastly, I'm sure you all want to know about it. we'll give you certificates of attendance to this event, and in order to get them, you'll have to complete a post-event survey that will help us see how much you've learned, what you've enjoyed about the event. And that will be sent out to you via email, and we'll also put the link on the Slack channel. I'm really amazed by the participation and the number of people we had for today. So thank you for joining us. We hope you enjoyed it. And if you have any more questions, you can put them on the Slack channel, and we'll try to answer as many of them as possible. Thank you very much, and bye-bye, everyone.